Namaskar and good evening, everyone. I welcome you all for today's webinar on Lung Cancer Connect. And with immense pleasure, I would like to invite Dr. Nikhil Pandey, who is Consultant Medical Oncologist, HCG NCHRI Cancer Center, Nagpur, for the welcome and introductory note and to set the ball rolling. Over to you, sir.
Thank you. And good evening, everybody, for the kind invites and for the kind words. Today, we would like to welcome you on board for the second day of the session. Second day, it's going to be a real pleasure for we have great speakers and we have a great session lined up ahead. So without taking much word, I would invite Dr. Amol Dongre sir, who is the medical oncologist, consultant medical oncologist at Alexis Hospital, to begin the session. And sir is actually also our conducting organizing secretary. And over to you, sir.
Thank you, Nikhil, and a very good evening. I can see that you just got up from your exhaustive, I guess your yesterday's day was quite exhaustive. That's why you're looking so tired. So anyways, without wasting much time, we'd like to start my presentation. So this is a session which has been sponsored by Pfizer, and I'll be talking on lorlatinib as first line treatment option in ALK positive NSCLC. Yeah. So as we all know, worldwide lung cancer is the second most commonly diagnosed cancer and the leading cause of cancer death in 2020. It represents almost 1 in 10 cancer diagnosed and 1 in 5 deaths as far as NSCLC is concerned. It almost accounts for 80 to 85% of all lung cancer cases, and the 5-year survival rate is really dismal. It is overall it is 25%, and for a distant metastasis it's hardly 7%. As we all know that we are moving from conventional chemotherapy to targeted to immuno. Likewise, from pathological point of view, we are moving from initial histopath to molecular to now precision diagnosis. So treatment selection is also moving from being initially histology driven now to a targeted or oncogenic driver. So I think lung cancer is the most oncogenically addicted tumor, we can say, because whatever mutations we see in lung have not seen in any other type of cancers. So it is lung is an oncogenically addicted cancer, and we know that based on this, now our treatment is primarily tailored based on the oncogenic drivers, initial histology, and then oncogenic driver. So this is basically a slide which shows the lung cancer incidence in India. So you can see this estimated number of incident cases from 2018 to 2040 in lung cancer for both sexes and all ages. So you can see by 2040, almost the incidence of lung cancer is 1,19,370. And if we see the lung cancer mortality, then again by 2040, it's almost like 1,11,804 lung cancer mortality. So it is really, really very huge. And this is the data, so Globocon data 2018. So as I already said that, lung cancer is oncogenically addicted tumor. So as we all know, there are a lot many mutations. So ALK mutation is the second most common targetable genomic change mutation in lung cancer after EGFR mutation. And you can see this is a paper, original article published by Amanjeet Bal et al. That is ALK gene rearranged lung adenocarcinomas, the molecular genetics and morphology in cohort of patients from North India. And you can see that after EGFR, the most common is ALK, which comprises around 7.9%. And then followed by the rarer ones like ERB-B2, BRAF, PIK3CA, NRAS, MET, MEK1, and no oncogen driver identified in almost 36% of the patient. So it is the second most common mutation. So, yeah. If we see ALK rearrangement in lung cancer, they are typically adenocarcinoma histology. They are typically, but not always, patients are never smokers or light former smokers. It tends to occur at younger patients, and there are diagnostic techniques now available for the identification of ALK mutation, and EML4 ALK and EGFR are mutually exclusive. So you can't find both the mutation in a single patient. So how there's a discovery of this EML4 ALK fusion in NSCLC. So what exactly is ALK positivity in NSCLC? So basically EML4 ALK fusion in NSCLC is nothing but a type of gene rearrangement, which we call it as an inversion, that occurs when a chromosome is broken in two places and the resulting piece of DNA is reversed and reinserted into the chromosome. So you can see this, you know, there's a typical gene rearrangement that happens, that is called as inversion. And when this chromosome is break into two pieces, the resulting piece of DNA is reversed. So this piece is reversed and this get reinserted into the chromosome. And what we get is the ALK positivity. So EML4 ALK fusion was initially reported way back in 2007. And so if we see since we detected this EML4 ALK translocation in 2007, there starts the, ALK inhibitor development timeline from there. So 2007, we detected this translocation. In 2012, crizotinib, it is the first generation ALK inhibitor which has been approved in NSCLC. Then in 2015, the second generation ALK inhibitors like ceritinib, alectinib, and brigatinib has been approved. Brigatinib 2015, 2017. Again, then you have second generation ALK inhibitors like alectinib and ceritinib was approved for first line use. Again, in third generation, then in 2019, lorlatinib has been approved and has been discovered. And then in 2021, US FDA gave approval for lorlatinib in frontline NSCLC with ALK positivity. So you can see 2007 detection, then 2012 first crizotinib, then ceritinib, alectinib, then second generation again, then 2019 third generation lorlatinib, and 2021 we get lorlatinib as FDA approval. So what are the current treatment options for ALK positive and why there's an unmet need for ALK inhibitor in these patients? So as I have initially mentioned that ALK positive NSCLC patients are generally young. The median age is around 50 years and they are non-smokers or light smokers. So CNS metastasis is very common. Almost 20 to 40% of untreated ALK positive NSCLC patients have CNS metastasis at diagnosis, and they are associated with poor prognosis. Also, it's not only just a CNS metastasis, but emergence of resistance mechanism that includes ALK resistance mutation and CNS metastasis due to this inadequate penetration of some currently available treatment options continues to be a treatment challenge even with availability of second generation ALK TKIs. So there is a need for additional ALK TKI that in untreated patients prevent the emergence of resistant subclones and with improved CNS penetration. So we need good NSCL ALK inhibitor for two reasons. One is for the CNS penetration, second thing to overcome the ALK resistance. So lorlatinib, it is a third generation ALK TKI, which is a selective ATP competitive, highly potent third generation ALK TKI. It has excellent brain penetration to address the brain metastasis, almost 75%, and it has the potential to improve clinical outcomes with overall and intracranial activity in patients with previously treated ALK positive advanced NSCLC. In addition, upfront treatment with lorlatinib could completely suppress or at least significantly delay target resistance, leading to more durable clinical benefit, and that is what is the unmet need for ALK positive NSCLC. So what exactly is the lorlatinib design and what is the precise mechanism of action? So it was basically designed to address this unmet need in ALK positive NSCLC, metastatic brain disease, and acquired resistance to the first or second generation ALK TKIs. So I know this is a very complicated biochemical structure of lorlatinib. So you can see this is the crizotinib structure and this is the lorlatinib structure. So this so basically this, if you see the crizotinib structure and if you go to this, and this is the lorlatinib structure where there is, in addition to the this molecule, it has additional N minus derivative which is there to overcome the resistance mechanism and for penetration. So with this effective CNS penetration and retention, and it almost binds with high affinity to most ALK resistant mutations. Now coming to the trial, that is CROWN trial, how lorlatinib has been got the FDA approval in advanced ALK positive lung cancer. So this is the CROWN trial wherein they took patient who have stage 3B to 4 ALK positive NSCLC with no prior systemic therapy with a good performance status of 0 to 2, ECOG PS 0 to 2, who have asymptomatic treated or untreated CNS mets and more than one extracranial measurable target lesion as per REGIS criteria with no prior radiation required. They have been randomized in 1:1 with lorlatinib 100 mg versus crizotinib 250 mg. They were also stratified based on presence of brain mets and ethnicity, Asian versus non-Asian. And the primary endpoint of this trial is basically progression-free survival by a blinded independent committee, whereas the secondary endpoints are PFS by investigator, overall response by again blinded independent committee central review, and intracranial overall response rate, duration of response, and intracranial duration of response, and OS, safety, and quality of life. So there's no crossover permitted between the treatment arms. So a total of 296 patients were randomized. It is a multicentric study wherein 23 countries and 104 study sites were included. And the patient was randomized from 2017 May to Feb 2019. A total of 149 to lorlatinib and 147 to crizotinib. 5 patients in the crizotinib arm did not receive treatment, and all these patients underwent restaging CT scan and brain imaging every 8 weeks. And by 2020, almost 103 patients in the lorlatinib group out of 149, 31 patients in the crizotinib group remained on study treatment with a median duration of follow-up for the progression survival was 18.3 months and 14.8 months respectively in lorlatinib and crizotinib arm. So baseline characteristics are well balanced in both lorlatinib and crizotinib arm. You can easily see brain metastasis at baseline almost equal number, 26 versus 27, prior brain radiotherapy 6 versus 7, and stage 4 90% versus 95%. So coming to the primary endpoint, that is PFS by blinded independent committee review. So you can see there's a clear-cut 12-month PFS rate, lorlatinib 78% as compared to 39% in the crizotinib arm. So you can see median PFS is not estimable at 12 months, whereas it is 9.3 months in the crizotinib arm with a hazard ratio of 0.28. Similarly, if we come to the PFS by investigator, which is a secondary endpoint, again, lorlatinib median PFS is not estimable, whereas it is 9.1 months in the crizotinib arm with hazard ratio of 0.21, again signifying a very good PFS benefit with lorlatinib. So if we see the progression survival across the subgroup, there's a subgroup analysis irrespective of the presence or absence of brain mets, ethnicity, ECOG, age, smoking, and histology. It clearly favors lorlatinib as compared to crizotinib across the subgroup analysis. If we see the overall response rate, again, it is better with lorlatinib, 76% responders, out of which 3% patients have complete response, 73 have partial response, 13 patients have stable disease, whereas progressive disease is found in 7% of the patient. Median duration of response was not estimable, again, whereas it is in crizotinib, it is 11 months, and median time to response is around 1.8 months in both lorlatinib as well as crizotinib arm. If we see the intracranial overall response by blinded independent committee review, it is again those patients who have measurable or non-measurable brain mets at baseline. Again, the intracranial responders are better in lorlatinib, 66% as compared to 20% crizotinib, whereas patients who have measurable brain metastasis, again, it is 82% versus 23%, with odds ratio of 8.41 in non-measurable, whereas it is 16.83 in the measurable metastasis at baseline. If we see the intracranial complete response rate, it is again better, 61% in the lorlatinib arm as compared to 15% crizotinib arm. Similarly, 71 with measurable brain metastasis and 8% only in the crizotinib arm, again favoring lorlatinib. If we see the intracranial time to progression, it is again median time to CNS progression is not estimable in the lorlatinib arm, whereas it was 16.6 months in the crizotinib arm with hazard ratio of 0.07 with significant p-value, again signifying the importance of lorlatinib in this group of patients. So coming to the overall survival, definitely overall survival is not estimable in both arms, but you can see the hazard ratio is 0.72 in these patients. So coming to the safety summary, any type of grade adverse event is equal in both arms, whereas temporary disruption occurs almost similar, 49 versus 47%, whereas permanent treatment discontinuation is more with crizotinib as compared to lorlatinib, even though it is not statistically significant. Fatal adverse event occurs in almost similar patients. Serious adverse event occur in 34% patient as compared to 27, and grade 3, 72%. But fatal adverse event are almost similar. If we see the all casualty adverse event with more than 10% difference in frequency, again, lorlatinib has high incidence of hypercholesterolemia and hypertriglyceridemia, whereas edema, weight gain, and peripheral neuropathy is more with again lorlatinib, but it is not that significant. So if we see the global quality of life score, again, it is better with lorlatinib as compared to the crizotinib arm. So to conclude, lorlatinib resulted in significantly longer PFS, significantly high overall and intracranial response rate, and improved global quality of life compared to crizotinib in first-line treatment-naive ALK-positive NSCLC. Lorlatinib intracranial response rate was 82% patient with measurable brain mets with a complete response rate of 71% and significantly longer time to intracranial progression. The safety profile of lorlatinib was similar to that reported in previous studies with grade 3 to 4 adverse event of more frequent with lorla than crizotinib. However, the majority of laboratory abnormalities that were asymptomatic and readily managed. So these results really supported the use of lorlatinib as effective first-line therapy for patients with advanced ALK-positive NSCLC. And even the NCCN guideline did mention first-line options for ALK-positive patients. Now you can see ALK reagent positive. If they discovered prior to first-line systemic therapy, then alectinib, brigatinib, or lorlatinib as category 1. Whereas if they are discovered during first-line systemic therapy, then either to complete planned systemic therapy, including maintenance or interrupt, and followed by preferred is lorlatinib, ceritinib, brigatinib, or crizotinib. So coming to the hyperlipidemia and hypertriglyceridemia, which is more frequent with the use of lorlatinib. So it has been advised that patients should, that hyperlipidemia is managed and resolvable through lipid lowering therapy and dose modifications, and one should not hesitate to use these lipid lowering agents if one is using lorlatinib on these patients. The CNS effect include change in cognitive function, mood, and speech. They are generally mild, intermittent, improved, or result upon dose modification. And these adverse drug reactions were reported frequency of almost 40%, with 12% of the patient experience more than one type of CNS effect. Baseline CNS matters were present in 72% of patients with CNS effects, and a total of 24 patients require more than one dose modification as a result of CNS effect. And out of these, 15 patients experienced a resolution of their CNS effect after temporary discontinuation or modification, whereas the median time to resolution of CNS effect was 12.5 days, and recurrence of CNS effects upon rechallenge at the same and reduced dose occurred in 6 and 7 patients respectively. So these are the dose modification guideline. So for a mild grade 1 adverse event, either you have to continue the same dose or withhold the dose until recovery, or rechallenge at the same dose or reduce dose by one dose level, that is by 25 mg. So of 100, one can use 75. Whereas for grade 2 to grade 3, withhold until the adverse event is less than grade 1 or rechallenge at one reduced dose level. For obviously grade 4 life-threatening, one has to permanently discontinue lorlatinib and instruct patient caregivers to report any changes in cognitive function, mood, or speech. Thank you very much. I'm sure I'm on time and would love to take any questions if at all there's. Thank you.
Thank you, sir. Yes, you were on time. So there's one question. Don't you feel there should be a study analysis of lorlatinib versus alectinib, as which one would be the best one to start one?
Well, see, if when I've gone through this lorlatinib data, it really looks impressive as far as CNS disease is concerned. I'm not very much, comfortable with the resistant mechanism, but yes, CNS wise, if you see, 71%, rate, CNS control rate is too good if we compare. I mean, there has to be a head-to-head comparison between this alectinib and lorlatinib, and I'm sure one might do it, but for sure, as of now, we have just comparison with crizotinib. So the data looks really good as far as CNS disease is concerned.
Yes, sir. Thank you, sir. Thank you for your valuable time. And I hope it is kind of a practice changing here, where I think now we would start lorlatinib or alectinib as a first line. I next invite Dr. Shruti Kate. Ma'am, as I can already see, Ma'am is a consultant and head in medical oncology at HCG Hospital, Nashik. And a dear batchmate and ma'am will talk about redefining survival expectation in NSCLC, about the keynote 189 and 407. Over to you, ma'am.
Thank you so much, Nikhil, for your kind introduction. And thank you, organizers, for choosing me to speak on this wonderful, relaxing Sunday evening amongst all the great speakers. And also, this, as we know, is a sponsored session from MSD. I have been contracted, and those are my disclosures. My slides, I think, are on the way. Are you sharing from your end, Arham? Yes, thank you. So the title of my talk is Redefining Survival Expectations in NSCLC, the keynote 189 and keynote 407. Next slide, please. Next slide, please. So for a long time, and the outcomes of metastatic non-small cell lung cancer have been very dismal. And we have had a paradigm shift in the way we approach these patients now. We have moved from treating non-small cell lung cancer as one disease to a histological choice of treatment vis-a-vis the molecular subtyping and precision oncology based treatment for this disease now. So, and definitely for the patients who do not have a driver mutation, immunotherapy along with chemotherapy has shown light at the end of the tunnel. And for many years, the outcomes were not very great. And rightly so, we have newer survival expectations from these patients now. Next slide, please. If we look at the numbers, lung cancer is a prominent cancer. If we look at the Globocan 2020 data, both sexes, all ages together, lung cancer accounts for, stands as fourth in terms of incidence and mortality. Next slide, please. So it's definitely a problem that needs a solution. And for many years, we were stuck at just, giving a grave prognosis to these patients. But now we know that there are some patients who can live longer even with a stage 4 disease. So the current treatment options for these patients for upfront treatment, the first and most important is smoking cessation that has to be highly encouraged. Recently, I was part of a survey, and I just came to know how ignorant I was regarding dealing with the smoking cessation for the patients. I mean, we should definitely take up in a bigger way, and definitely has to be discussed with the patients with a good insight and knowledge about what are the available means of smoking cessation for the patients who are current smokers. Then systemic therapy is the backbone, which is offered to all patients 0 to 2 PS conventionally. But here again, I would want to stress on the patients who are PS3. I would suggest that those who have become PS3 at the onset of the disease and were fine before the development of the disease, they should be given a chance. At least the workup needs to be done, at least the NGS on the biopsy needs to be done. And many patients, we all have that kind of an experience where you can offer a precision oncology based treatment, and now we have immunotherapy at our disposal, which can be offered as a single agent to certain patients, and they can dramatically improve based on the disease profile. So the decisions are always taken in a collective way, looking at the histology, the molecular pathology, of course, patient-related factors like age, performance status, comorbidities, preference has to be given a due importance. The options are for the driver mutation negative patients, immunotherapy in combination with chemotherapy, or chemotherapy with an anti-angiogenic therapy, and for the driver mutation positive patients, TKI based on the molecular diagnosis. Next slide, please. So chemotherapy has been the backbone for treatment of these patients for many years. We now know that the doublet platinum chemotherapy is the standard of care. Cisplatin-based chemotherapy is slightly superior, but you have to choose your patient wisely because many patients will develop an adverse event or severe toxic effects to cisplatin, and it is better avoided in a metastatic disease scenario. We also know that 4 cycles of chemotherapy is quite good enough, and 6 cycles may not be required to improve an overall survival. Next slide, please. The landmark paper, of which even Tata Hospital was a part of, which actually defined the way in which chemotherapy backbone is chosen based on histological subtype, is this. And now we know for a squamous histology, we do not use pemetrexed. For a non-squamous histology, pemetrexed platinum is the chemotherapy of choice, which scores over and above the gemcitabine cisplatin chemotherapy in non-small cell lung cancer. Next slide, please. So we are here to discuss the role of first-line immunotherapy checkpoint inhibitors in combination with chemotherapy in metastatic non-small cell lung cancer patients. So why immunotherapy? Next slide, please. Yeah. So evading immune cell recognition and destruction is a key hallmark of cancer. Cancer cells do that by ineffective presentation of tumor antigens to the immune system, recruitment of immunosuppressive cells, release of immunosuppressive factors, and T cell checkpoint dysregulation. That's why immunotherapy does not focus just on the cancer cells, but on the immune system, facilitating the recognition of cancer cells by the own immune system. The toxicity profile we are all familiar is that's different, and you expect a long-term survival for 20 to 30% of patients, which was never heard of in non-small cell lung cancer. Next slide, please. So why in combination with chemotherapy? What happens is when the tumor is alone, when immunotherapy is used alone in a cold tumor which does not have a PD-L1 sensitivity, the effectivity is not much. The immune cells are unable to change the tumor microenvironment because there is a very tight regulation of the T regulatory cells. When you use immunotherapy in combination with the chemotherapy, a cold tumor becomes a hot tumor. The T regulatory cells are reduced, CD8 positive T cells are increased, and APCs infiltrate the tumor microorganism, resulting in a very effective way in which the body's immune system recognizes the tumor. Next slide, please. So let us discuss one by one these 2 keynote trials. Keynote 189. Next slide, please. So Keynote 189 was a phase 3 study of pemetrexed platinum chemotherapy in combination with pembrolizumab as a first-line therapy for metastatic non-small cell lung cancer. Histologically confirmed non-small cell lung cancer patients were enrolled who had a measurable disease and did not have a sensitizing EGFR or ALK mutation. No prior immunotherapy treatment or systemic therapy was allowed. These patients were randomized into 2:1 randomization to receive pembrolizumab in combination with a platinum doublet, pemetrexed plus carbo or cis for 4 cycles, followed by a maintenance pembrolizumab with pemetrexed. In the standard arm, pemetrexed carboplatin was used along with placebo, followed by pemetrexed plus placebo as a maintenance. A crossover was allowed, and a predetermined stratification factor of PD-L1 expression, platinum use, and smoking status were considered. Primary endpoint was PFS and OS, and also the secondary endpoints were safety, ORR or DOR. Next slide, please. So these are the baseline characteristics of the intention to treat population. Median age of the patients was 65 years. Majority of the patients were male, 62% in the pembrolizumab arm versus around 52% in the placebo arm. Brain metastasis was present in around 17% of patients. PD-L1 expression was negative for 1/3 of the patients, while it could not be estimated for around 5 to 7% of patients. Majority of patients did receive carboplatin. Next slide, please. Liver metastasis was present in around 16% in the pembro arm versus 23% in the placebo arm, and baseline tumor size as well was well matched in both the arms. The histology was adenocarcinoma in majority, while it was not specified for around 2% of the patients. Next slide, please. So this is the 4-year follow-up of overall survival for the pembro and chemo versus chemotherapy intention to treat population. I think Arham, yeah. So if we look at the 24-month survival, the 2-year survival, it was around 45% for the pembro arm versus 27% in the chemo alone arm. The responses were durable, and at the end of 36 months, around 31% of patients were surviving in the pembro arm versus 17% in the chemo alone arm. Overall survival median was 22 months versus 10 months in the chemo alone arm, and hazard ratio was statistically significantly lower. It was 0.6. Next slide, please. So it is very evident that the curves are separated, and they continue to separate as the time passes. If you see the curves by the PD-L1 classification, it was the highest overall survival was for the PD-L1 more than 50% group of patients. But if you look at the PD-L1 negative population, the hazard ratio is 0.5, and the pembro plus chemo arm has given a survival of 17 months versus chemo alone arm at 10 months. Next slide, please. If we look at the progression-free survival, median progression-free survival was 9 months versus around 4.9 months for the placebo plus chemo arm. At the end of 2 years, 22.6% patients were progression-free in the pembro chemo arm versus just 4% in the chemo alone arm. And at the end of 36 months, again 11.8%, nearly 12% of the patients were still progression-free versus just 1% of patients in the chemo alone arm. Next slide, please. Again, these are the curves for the progression-free survival as far as the distribution of PD-L1 in the cohort is concerned. And here again, you can see that the statistically significant difference is achieved in all the subgroups. Next slide, please. If we look at the forest plot for all the subgroups here for PFS, you can see that the pembro plus chemo arm has fared better in all the subgroups. Next slide, please. And if we look at the PFS2 again, in the pembro chemo arm, it is 17 months versus 9 months despite the crossover. So again, very statistically significantly achieved difference in the two arms. Next slide, please. Again, for the PFS2, irrespective of PD-L1, the difference can be seen very clearly. These are exactly how you want to see the curves separated till the end. Next slide, please. And actually, the curves are widening towards the end. So the overall response rates were again higher in the pembro chemo arm, and the median duration of response was for all patients taken together around 12.8 months, which was around 15 months for PD-L1 more than 50%, and subsequently lower. So if you can see that if even in the chemo alone arm, if you look at the PD-L1 negative population, so these have been doing poorly, and this definitely tells us that this is a group which is actually biologically a very bad subgroup of patients. But if you look at the combination of chemo plus immuno, that is the only way you can increase the response rates or give a better survival. So this is a follow-up of overall response rate and overall survival for patients who completed 35 cycles of pembro. So 2 years of pembrolizumab, OS was 79.6%, and at the data cutoff, 80% of the patients were alive. Next slide, please. So if we look at the updated analysis of the study crossover, around 40% of the patients overall crossed over to the immunotherapy arm, and effective crossover in the intention to treat population was around 53.9%. So this is very significant, and if you can see here that there were patients around 1/3 of patients, or nearly 1/3 of patients who died without receiving subsequent therapy in the placebo chemo arm, while 50% could effectively cross over to the immunotherapy arm after receiving placebo. Next slide, please. So if you look at the adverse events for the intention to treat population, more than 90% of patients did have adverse events, but they were well managed. And if you look at the grade 3 to 5 toxicity profile, it was largely related to the immune mediated side effects, and though the non-immune mediated side effects were almost equally balanced in the chemo and the IO chemo combination arm, while the immune mediated side effects were restricted to the chemo plus IO arm. Amongst this, only 12% had a grade 3 to 5 immune mediated side effects, out of which 9% did require discontinuation of the treatment. Next slide, please. So if we look at the patient, look at the adverse events with frequency more than 20%, majority of these were very mild: nausea, anemia, fatigue, constipation, diarrhea, in that sequence, and they were well balanced in the two arms. Next slide, please. If you look at the immune-related toxicity, overall, the most common immune-related toxicities were hypothyroidism, hyperthyroidism, which were mild in majority of the patients. The side effects which were actually grade 3 and above were pneumonitis, colitis, or hypophysitis. Next slide, please. So it's important to recognize these side effects early and manage the patients with steroids at the earliest outset of a grade 3 or above toxicity. So the key takeaways from Keynote 189 is that with more than 3 years of follow-up, definitely IO chemo combination has provided an overall survival and a PFS benefit for these patients, and those who received around 2 years of pembrolizumab had durable responses and were most of them were alive at the time of data cutoff. Toxicity profile of IO and chemo combination is very much manageable, and it has become a standard of care therapy for these patients who are newly diagnosed with metastatic non-small cell lung cancer. Next slide, please. Coming to Keynote 407 for the squamous group of patients. Next slide, please. There is a phenotypic difference in the way in the squamous non-small cell cancer presents. A majority of these patients are males, and it is strongly associated with smoking. Majority of them are also have an advanced age at the time of presentation, and like you can see in this bar graph, over these years or decades, the survival has not really changed before the advent of immunotherapy, and very few survival gains with the change of chemotherapy backbone or anything. Next slide, please. So this was a fairly simple design, Keynote 407, where the patients were randomized into 1:1 ratio to receive pembro with platinum with Pacli or nab-pacli for 4 cycles, followed by pembro for up to 31 cycles. And in the standard arm, placebo was given in combination with the same chemo backbone. Primary endpoint was PFS and OS, and secondary endpoints were ORR, the duration of response, and safety. Next slide, please. So the baseline characteristics of Keynote 407, here we can see that the percentage of men in in both the cohorts is higher as compared to Keynote 189, and majority of the patients are smokers. If we look at the distribution of PD-L1, around again 1/3 of the patients were PD-L1 negative. Majority of patients did have paclitaxel as a chosen backbone in the chemotherapy. Median age was in the study as 65. Next slide, please. So the final analysis of overall survival for pembro plus chemo combination in the intention to treat population was again very statistically in favor of the IO plus chemo combination. So at the end of 12 months, 64% of patients were alive as compared to 50% of patients in the chemo alone arm. And at the end of 24 months, here we can see that there is around 7 to 8% higher overall survival that is achieved in the chemo plus IO arm as compared to chemo alone arm. Next slide, please. If we look at the distribution as, if we look at the PD-L1 distribution for the overall survival curves, again, the difference was noticeable in both the subgroup of patients. Next slide, please. The progression-free survival was again statistically significantly better in the IO chemo arm, and at the end of 24 months, 18.6% of patients were progression-free in the chemo IO arm versus just 6% of patients in the chemo alone arm. Next slide, please. This difference was also again seen across the patients irrespective of the PD-L1 status. Next slide, please. If we look at the overall response rate, overall all patients taken together, the response rate was around 62% for the chemo IO arm versus 38% in the chemo alone arm. And again, even in the PD-L1 negative population, the chemo plus IO arm did give a 25 to 26% higher overall response rate as compared to the chemo alone arm. Again, there were many patients who were having an ongoing response at the time of data collection. Next slide, please. These are the curves for the duration of response. Next slide, please. And the PFS too. So at the end of 24 months, 32% of patients were progression free after progression in the first line setting. This difference, there's around a 12% difference in the, more than 12% difference in the chemo versus chemo plus IO arm. If you look at the median PFS2, it was 13.8 months in the IO chemo arm versus 9 months in the chemo alone arm. Next slide, please. Again, the difference was markedly different for both the subgroups, and here you can see that the actually PFS2 for the PD-L1 negative population is higher as compared to the PD-L1 positive population here. Next slide, please. Yeah. So this is the crossover adjusted overall survival. If you look at the IO plus chemo combination, it is 17 months versus the chemo alone arm, which is around 9 to 11 months. Next slide, please.
My apologies, ma'am. You are left with just 1 minute to conclude your presentation. Thank you.
Yes, I'll be concluding. Yeah, thank you. So if you look at the all-cause adverse events and the immune-related adverse events, majority of patients had milder events. And if you look at the immune-mediated adverse events, again, similarly, around 1/3 of the patients did have immune-mediated events. And again, similar to Keynote 189, the grade 3 to 5 adverse events were around 10%. Next slide, please. So similar adverse events. Next slide, please. So majority of the immune related adverse events are thyroid related and are quite well manageable. Next slide, please. Yeah, so takeaway from Keynote 407 is that at the end of, yeah, next slide, please. That Pembro-IO combination is definitely proven to provide a better OS and PFS benefit to patients when used in an untreated population. And definitely those who complete 2 years of Pembro are doing very, very good. The safety profile is quite manageable, and this definitely is a standard of care for patients who have metastatic squamous cell carcinoma irrespective of PD-L1 expression. Next slide, please. Next slide, please. Next slide, please. So there's a pooled analysis of patients who did not have PD-L1 expression. Next slide, please. This is a pooled analysis of 3 Keynote trials. And here you can again see that the overall survival for these patients is median 19 months versus 11 months for the chemo alone arm. Next slide, please. And very well separated OS curves. Next slide, please. Yeah, so this is the pooled analysis of PFS. Next slide, please. PFS2 and the overall response rate. Next slide, please. So Pembro plus chemo, a response rate of 50% versus a response rate of around 30% for chemo alone. So next slide, please. Yeah, so I'm done. Thank you so much.
Thank you, ma'am. Thank you for such a wonderful and lucid talk. And I agree, it's a Sunday evening. Ma'am, can I just ask one question? So is it Pembro plus chemo for everyone?
Yes, Nikhil. So the data says that if there is no driver mutation, the best response that you can achieve is with a immuno plus chemo combination. So I would want to use an immuno plus chemo combination for all the patients. Of course, we do not have data of the patients with brain metastasis, you know, analyzed separately for this group of patients, but I don't think there will be a difference because if there is no driver mutation, then you know, all these patients would actually respond to an IO chemo combination. That is what is evident from the 4-year survival update of these trials.
Yes, ma'am. So irrespective of PD-L1 status, it is Pembro plus chemo.
Yes.
So why do we end up doing PD-L1, ma'am? So
and we still do it. So even though we have data, we still do it. But yeah, I have not. I mean, there are other studies which say that you may actually drop the chemotherapy for patients who are, you know, PD-L1 more than 50%. So that is one thing. And again, I would say till the time we had results for these patients, we were not very sure what is happening to the PD-L1 negative cohort. But as of now, if you see from here on, I mean, even if you want to skip PD-L1 and use a chemo IO combination, it should be fine.
Yes, ma'am. Thank you so much, ma'am. Thank you. And thank you for sticking to the time. If there are no further questions, it is my extreme pleasure to invite Dr. Kumar Prabha, sir. Sir is professor and HOD of medical oncology in TMH, Mumbai. And sir would be talking about perioperative therapy, neoadjuvant and adjuvant immunotherapy. It is immense pleasure to give the floor over to sir.
Thank you, Nikhil. Can I share my slides? My slides are visible?
Yes, sir.
And I'm audible, Nikhil?
Yes,
Yes,
sir.
sir.
Yeah. At the outset, I'll thank the organizers, especially Dr. Nikhil and Dr. Amol for inviting me. And thank you, Shruti. That was a nice lecture. So I'll start my talk, and that's regarding perioperative therapy, neoadjuvant and adjuvant immunotherapy. And this is a bit of a tricky one, a bit less tricky now, but then also a bit tricky topic. We have seen many drugs do a good job in palliative setting. You put them in adjuvant, they start faltering. We were not certain about what will happen to immunotherapy. Now, at least we have 3 situations. That's what we'll be talking about, where you have in lung cancer drug, which in one of them, increasing the life, and other 2 of them controlling the disease, and randomized trial settings. So that becomes important, and seeing this data looks like we'll be talking about this more and more as the time goes by. Starting with why we want to talk about it. We want to talk about any treatment depending upon if there is unmet need or not, especially when we want to add a new treatment. And what we see here, lung cancer, unfortunately belongs to one of those group of cancer where in stage B patient also, you do have a significant proportion of patient not surviving after 2, 3, or 4 years. And here the survival data looks good, but if you take stage 1B patient, then also almost 40% patient, they fail as the time goes by, and that you get reflected in here. That is for survival, but if you take for disease control, it becomes around between 60 to 70%, and a 5-year almost 68%. This we are talking about a very small tumor. The moment it goes to around stage 3, we start talking about 2-year survival of 55% and 5-year survival of 36%. And if you look for disease control rate for these patients, almost in stage 3, 70% and beyond patients, they start failing, and they do fail within 2 years. And that's the reason we want to explore further treatment in this setting. There has been a stagnation as far as this stage is concerned for treatment development in last few decades. That is beyond adjuvant chemotherapy. We didn't have any development here in this setting. And that's the reason we are excited about knowing that is there something happening. In recent past, we did have significant advances that which is people have seen that it has happened in advanced disease, that is targeted therapy, IO. We saw that data in the previous talk, and the chemo IO, and also the biomarker driven approach, which decides which one will be giving it. We also have seen, not in Indian context, but overall, more in the Western context, that the screening has shifted. The diagnosis of patients more in early stage, it is a small number, but looks like it has impact. As I talked about, post-operative cisplatin-based chemotherapy, which was some time back, which showed that it benefits patient, and all of you can see that these were the trial which came in 2000, early 2000, and subsequently we didn't have much to show for improvement. It does reduce the lung cancer deaths by 6.9% and increase non-lung cancer death by 1.4%. So overall, if you barter it, then it comes out to be around 5% absolute improvement in survival. I always tell my colleagues and my students that remember, this 5% is not sacrosanct for every patient you give adjuvant chemotherapy. It may be 1 to 2% for stage 1 patients, but if it will be around 13 to 14% or 15% for stage 3 patients. And if you take N2 disease patients, then it will be different, it will be far more. So it does change depending upon the stage, and only 5% remembering is fine. But in the application, I may not give a patient where there is a risk of chemotherapy with a stage 1B patient of tumor of size of 4 centimeter. But if the patient has N2 disease, then yes, I'll find out ways and means to see that we are able to give them adjuvant chemotherapy because the benefit is substantial. So it is important that what kind of patient receives what kind of benefit is important in the setting. We have known about it now for some time, that in adjuvant setting, if we give osimertinib to the patients who are EGFR mutation positive, looks like across the stage it benefits, and for disease-free survival, the gap between the curve is pretty wide open. And we do have this discussion regarding should we wait for OS or not, but you do have FDA label for it, and you have a DCGI label for it to be used in the clinic. And I think, yes, patients do deserve to be talked about this treatment, and yes, finally they are to choose. We talk about checkpoint inhibitor, but as far as immunotherapy is concerned, people have tried other immunotherapy. This is one of the protocol where I was also a part of it, and there was a huge anticipation for MAGE, A3, as a vaccine to be used in this setting to hope that it will improve outcome. It turned out to be that it was let down, not only in melanoma, also in lung cancer, and you can see the data here. So that time it didn't work. Neoadjuvant chemotherapy, there has been a randomized trial comparing it. Apart from that, we do have indirect meta-analysis, which has compared the neoadjuvant chemotherapy versus adjuvant chemotherapy in lung cancer. And it appears whichever you give it, the benefit looks similar, suggesting that in the patient who's going to receive adjuvant chemotherapy, if you're giving the treatment in neoadjuvant chemotherapy, you are giving the similar kind of treatment with a similar benefit for these patients. Do we have theoretical advantages for neoadjuvant immunotherapy? Yes, that appears that we do have. We do want, when we give immunotherapy, that there is a tumor inside, hoping that high antigen load, which releases from the dying, untreated tumors, that may allow better priming of immune system. Immune system is fit because we have not given any other therapy. No significant clonal evaluation has happened after treatment, which can happen after adjuvant therapy or after the initial treatment, local treatment, what we give. Opportunity to accurately study the effects of IO, which happens more if you are giving the treatment and then you have a tissue to analyze. Ability to assess the efficacy of the therapy, and also one important one, shortens the time frame for completion of the trial because you do get early surrogate marker, and we will see about it in lung cancer also. Neoadjuvant immunomonotherapy, there are many of them, and what it tells you that what we see in the scan not necessarily matches in the tissue what we see. And the tissue what we see, that you do have pathological response rate in by and large single to double digits, but major pathological response, which has got varying definitions, but if you remember a simpler one, that less than 10% of the viable tissue, it goes pretty high, and it has gone up to around 45, 46%, which is encouraging. The moment we add chemotherapy to immunotherapy, and what we observe here, that CT scan, when they compared with pathological response, again, the discordance remains. But the pathological response increases, what we have seen with single agent immunotherapy or immunotherapy alone, and also the major pathological response becomes substantial, and that starts looking very promising. And when we see this data as compared to chemotherapy, what we have known, then we know that there is something promising here. This led to this CheckMate 816 study, which I'm sure we'll be talking till sometime till we have many more phase 3 trial in this setting, which was a phase 3 randomized trial for neoadjuvant immunotherapy, where the key eligibility criteria was the patient with stage 1B, that is 4 centimeter and more disease, to stage 3A, ECOG performance status 0 to 1, no EGFR and ALK mutation positive patient, stratified between 3A and others, PD-L1 less than and more than 1, and gender. The primary endpoint was pathological CR and event-free survival, and both of them were primary endpoint. We have all the regular secondary endpoint which are important. Some of them is available, some of them will be waiting for. In the design, patient received immunotherapy, that is 3 cycles with chemotherapy. Again, important to remember is only 3 cycles of immunotherapy, which all we want, especially in the context for treating the patient, and also the cost, which becomes a major factor in our country. Compared to chemotherapy in these patients, and they underwent radiological evaluation, then underwent surgery within 6 weeks of the treatment. These were the patients. Good number of patients, that is 358, 179 in nivo plus chemotherapy arm, 179 in chemotherapy arm. Almost all of them received neoadjuvant nivo plus chemotherapy, that's 98%, completed 94%. And what we see finally, 83% patients underwent surgery. In the chemo arm, 98% received neoadjuvant chemotherapy, completed 85% in all probability because of the side effects of progressive disease, and finally 75% of the patient underwent definitive surgery in these patients. And these are various reasons why they didn't go surgery, highlighting that this is one of the issues which comes in lung cancer. And if you will see in almost all neoadjuvant trial that you do have a group of patients who don't undergo surgery after this treatment. This is the pathological response rate. And if you see all the stages wise, it appears the pathological response rate was higher if immunotherapy was added to chemotherapy as compared to chemotherapy. And an absolute number, it was 25% compared to 2.2% in chemotherapy alone arm, suggesting that immunotherapy plus chemotherapy was better as far as the pathological response is concerned, and that was a primary endpoint. But what we want to see, that we want to see the data in many ways to see that what we saw for primary endpoint is true or not. And this is a good waterfall plot which suggests what we see, the amount of the patient where you had the depth of the response as compared to the patient who received chemotherapy. Here it is immunotherapy plus chemotherapy. it is obvious that it was far higher for patients receiving immunotherapy plus chemotherapy. So what it means that median residual viable tumor, when they saw it, it appeared that it was 28% in stage 1 and 2 and 3 as compared to 79 and 70% in the patients receiving chemotherapy alone in stage 1, 2 as compared to stage 3. So a big difference in the viable tumor which is left out after giving this treatment. So sure, this was something which was promising. As far as the surgery is concerned, looked like it was fairly well balanced in both the arms as far as the type of surgery was concerned. These were the patients where, if we see the R0, R1, and R2 resection, they were similar in both treatment arms. And the number of lymph nodes was dissected was also similar in both arms, suggesting that kind of surgery done could not have impacted the outcome what we got. 90-day surgery-related complication, it also appears that in both arms it was similar, some differences, but doesn't appear that immunotherapy is increasing as far as the surgery is concerned in this arm of patients who receive immunochemotherapy. This is the latest news on this study, and which everyone was waiting for. That is, does the pathological response impact the event-free survival? And it does appear the event-free survival was 31.6 months in the patient receiving immunotherapy plus chemotherapy as compared to 20.8 months in those receiving chemotherapy. And I think this is a welcome news with a hazard ratio 0.63 and which was statistically significant and looks like clinically meaningful. I'm sure we will all want to wait for and want to know what is the overall survival. Based on this, US FDA has given approval for use of this treatment in this setting. And I think so now we do have a dilemma about what do we do in this setting when you have adjuvant immunotherapy and new adjuvant immunotherapy approved in the similar setting for these patients. But one of the advantage, what we have seen, it is there that in these patients, you do have you can give only 3 cycles of immunotherapy and get away with it. And again, which I talked about, does this ensure that we will have a OS benefit? We don't know. We need to watch for it. Second study, that is adjuvant immunotherapy in this setting. This is Empower 010. This has been talked about more, and what has happened in this, in the same group of patients, what we saw in the new adjuvant setting, after chemotherapy, they were given atezolizumab versus best supportive care, and with the primary endpoint, DFS, and with those regular secondary endpoint. These were the kind of data analysis was planned, that is hierarchical analysis, one by one. If it is positive, people went going down to analyze the whole cohort. Initial was more than 1% or 1% of PD-L1 in stage 2 and 3A patients. These were the baseline characteristics, looks like fairly well balanced. And in the primary endpoint for the first hierarchical analysis, it was positive, statistically and clinically meaningful. It appears in the subgroup analysis, it is positive in most of the patient, but for EGFR ALK, not necessarily, because this is one of the an earlier presentation I have got the slide, but if you take the final publication, then for EGFR mutation positive and ALK mutation positive patient, it appears the diamond is on the 1, so looks like they may not benefit. One of the another aspect is what happens to the patients with a different subgroup of PD-L1 positivity. This is the second analysis, that is all randomized patient for stage 2 and 3, and again it appears clinically and statistically meaningful. Again highlighting that yes, it appears in all subgroup you do have a benefit, but if you take EGFR, ALK, and TC less than 1%, looks like they may not benefit. The important question here is not TC more than and equal to 1%. The important question is what happens if you subdivide between more than 1% and less than 50%, and that subgroup of patient, what happens? This is overall a whole group of patients, that is stage 1 also included here. It appears in the usual term, statistically meaningful, but as far as this study was concerned, this has not crossed the significance of boundary at this interim DFS analysis, so people are waiting for further analysis for this this overall cohort of the patients. This is the overall survival data. Looks like TC 1% and more than 1%, diversion starts happening, but in others, at this moment, doesn't look like diversion is happening. So we need to wait for more data as far as this outcome is concerned. Safety looks meaningful. It looks like it is safe to give if we are careful, but yes, we do have almost 18% of the patient where you have to discontinue this treatment if the side effect is there, and that should be at the back of the mind. Coming to stage 3 patient, chemoradiation is better than radiation. Dose escalation for radiotherapy doesn't help, and we know this data for a long time. That is 4-year survival, better for patients receiving chemoradiation followed by immunotherapy, that's durvalumab, as compared to only giving chemoradiation here. And what I want to highlight for people here is that 36% is a subgroup of patients who have received immunotherapy subsequently when they have progressed. It would have been important to see that if this was not there, if they have not received any immunotherapy, what would have been the curve? And that would have highlighted more about the role of this immunotherapy in this setting, as far as these patients are concerned. There are some unanswered questions. PD-L1 testing was not required in this study, so not every patient had it. PD-L1 status was determined before chemoradiation, so post-chemoradiation is not feasible, but we all want to know what will happen if you do it. Cutoff of 1% was analysis done by, as it was asked by EMA, do we really need to talk about it, or we can forget it? But as far the data is concerned, looks like it's not tough to forget. And people do want to know that if immunotherapy can be given concurrently with chemoradiation or not. There are 3 studies. Looks like it's safer to do it, but we are waiting for outcome of these data. So with these data, the question, we know that it is useful in our patients, but remaining questions are PD-L1 negative patients, what happens? What is the optimal duration of the treatment? We give it for a year. Is it enough? Sequential chemoradiotherapy, is it good to give this treatment? Is 60 gray the optimal dose, or we should be giving the different dose? Chemotherapy-free regimen, is it possible? Can we avoid them? And concurrent immunotherapy, which I talked about earlier. There has been some movement on neoadjuvant immunotherapy, then followed by chemoradiation these patients, and this is one of the small study which was done. It looks promising in this setting also, but the question remains: the patient who progresses after neoadjuvant immunotherapy, then what do we do? How many patients failed concurrent chemoradiation, and who is best suited for this approach when we select these patients? And sure, we require phase 3 randomized to answer these questions. There are many phase 3 study going on neoadjuvant setting, and there are challenges, and also there are many adjuvant trial going on for immunotherapy. Sure, these individual trial has made an impact, and they are practice changing, but I'm sure we'll all be looking for these trials to convince us that as a concept, this needs to be implemented always. These are many questions in both the setting. If you have neoadjuvant and adjuvant both, which one we want to choose? Can we downstage the patients for make them resectable, which we usually don't do it now? What biomarkers identify the patient where we don't miss those patients who progresses, and what happens in long-term risk? Thank you so much.
Thank you so much, sir. Thank you for taking your time out and coming to this discussion. Sir, I just have one question. Whenever we talk about EDURA, that is trial, we always talk about EGFR exon 19 and exon 21. What happened to the rest of them, sir? Suppose we have gotten exon 18 or exon 20. So do we consider EDURA as the baseline, or do we consider durvalumab still, because there's no data to that?
So I think so. Apart from exon 20 insertions, looks like immunotherapy has an issue with the mutation positive patient. In spite of the recent data, again, the Chinese data showing that immunotherapy has a role. I thought most likely, except for ABCP, we won't be able to show that immunotherapy really works in mutation positive patient. But for EGFR mutation positive patient, there was a Chinese study of immunotherapy, again with bevacizumab with chemotherapy, and it showed a significant benefit. So looks like it is not out. For ALK, looks like it is out, but not for EGFR. But if I have exon 18, the kind of data what we have seen with EDURA, and that's why I always say, once your concept keeps getting proven, so we can debate today. If I have another trial like EDURA, most likely we won't be talking about it. I'll give you an example about it. EGFR mutation positive patient, data for PS3-4 in palliative setting is hardly any. But in 1 or 2, the kind of benefit what we have seen, you have an NCCN guideline without a single reference they gave it that it should be given. So ADAURA, the kind of benefit we have seen, I'll prefer that because there is a issue regarding the benefit of immunotherapy in that setting. But if we have 1 or 2 more trials showing the benefit like what we have seen with ADAURA, maybe with Exon 19 and 21 only, but that concept being seen more than once, people will be very hesitant in bartering with this with immunotherapy. But your question is valid. Maybe I'll be proven wrong because many times we try to extrapolate and we end up having egg on the face, and that's the reason I wait for a bit of a concept. Let the concept be seen more than once.
Thank you, sir. If there are no further questions, can I just invite Dr. Yashwant Kashyap? It is a BMS sponsored session, and sir is an assistant professor in Department of Medical Oncology at AIIMS Raipur, and he will be talking about role of dual IO therapy in treatment of metastatic NSCLC.
Good evening, everyone. Thank you, Amol sir and Nikhil sir, for giving me opportunity to present this platform. My slides are visible?
Yes, sir.
Sir, please don't call me sir. So today I will discuss about role of dual IO therapy in treatment of first-line metastatic NSCLC. I will be talking about nivolumab and ipilimumab. So I will be discussing about these 5 points: unmet need and immune cycle and this inhibitor synergy. Then I will be talking about CheckMate 227 trial.
Sorry for intervening, your slides are not moving.
So, about these 2 drugs. Next slide, please. So I will be discussing about these 2 trials, as dual IO-based regime has demonstrated better survival compared to chemo in first-line setting. So this in CheckMate 227 study, we have seen that patient with PD-L1 more than or equal to 1%, this drug combination has shown benefit. In CheckMate 9LA, we have seen that this drug nivolumab and ipilimumab have survival benefit even irrespective of PD-L1 expression. Next slide. This anti-CTLF4 inhibitor ipilimumab and nivolumab both work in a synergy. So anti-CTLF4 inhibitor basically leads to priming and activation of T cells, and in anti-PD-L1 inhibitor work in effector phase and lead to T cell activation. Next slide, please. So they work as complementary, and ipilimumab induces de novo anti-2 T cell response, and whereas nivolumab restores T cell function. Next slide, please. And this combined inhibition leads to distribution of activated T cells in tumor site and target killing of cancer cells. Next slide, please. So this is 4-year update of CheckMate 227 Part 1 trial, in which nivolumab was combined with ipilimumab therapy. Next slide. This is a phase 3 trial in which there were 793 patients. All were stage 4 or recurrent NSCLC with no prior systemic therapy, with no known EGFR or ALK mutation. Patient were of ECOG 0 to 1 and all had PD-L1 expression more than or equal to 1. They were stratified based on histology, squamous or non-squamous. They were randomized in 1:1 as nivolumab 3 mg per kg every 2 weekly with ipilimumab 1 mg per kg every 6 weekly compared to platinum doublet chemotherapy standard which we use. So there were 397 patients in nivolumab plus ipilimumab arm and 397 in chemo arm. So, and it was chemo-free regime, and treatment was continued till progression or up to 2 years. Primary endpoint of this study was OS. And patient with untreated brain mets or carcinomatous meningitis or autoimmune disease, they were excluded. And PD-L1 was done by centralized lab. And we have now follow-up data of 54.8 months. Next slide. Baseline characteristics were comparable in both the groups. You can see in this slide that more than in both the groups, around more than 50% patients were having PD-L1 expression more than in Nivo plus EP arm. 52% patient had PD-L1 expression more than 50%. Next slide. So this, as we have seen in other immunotherapy studies, this drug has in around at 3 months median OS was 17.1 months in Nivo EP arm, and chemo arm it was 14.9 months, but 3-year OS was 33% in Nivo plus EP arm compared to 22% in chemo arm, and similarly 4-year OS was around was 29% in Nivo EP compared to 18% in chemo only arm. So you can see that it has around 11% difference. Next slide. In based on histology, even in based on histology, Nivo plus EP arm has done better, and around 32% in non-squamous histology patient had 4-year survival of around 32% compared to 20% 4-year survival in squamous histology. Next slide. And this is also an important slide which shows that if patient is responding for initial 6 months, then such patient has 3-year response, 3-year OS of 70% compared to 39%. So around 30% difference in OS if patient has responded to this Nivo EP combination. Next slide. Overall response rate was better in Nivo EP combination. It was 36% in this group compared to 30% in chemo group. Median PFS was 5.1 months compared to 5.6 months in chemo arm. 4-year PFS was 14% in Nivo EP compared to 4% in chemo. Next slide. So this response duration of response was also longer in Nivo EP arm, 34% at 4 years compared to only 7% in chemo only arm. Next slide. This though toxicities were in adverse reaction were more than or equal to 10% in Nivo EP arm. Toxicity like fatigue, gastrointestinal were more compared to chemo, but they were manageable, which I will show in further slide. Next slide. Therapy due to therapy related even after patient who discontinued therapy due to toxicities like pneumonitis, rashes, and gastrointestinal grade 3, grade 4 toxicities, even they have done better in Nivo-IP arm, even after stopping discontinuation of drug, and ongoing response percentage was 53%. At 4 year, it was 44%. Next slide. So due to this, NCCN has this Nivo-IP is recommended as category 1, and for EGFR negative patient, it is for PD-L1 percentage more than or equal to 1%. This is a first line drug and is used. Next slide. So to summarize, this combination 4 year OS is 29% compared to 18% in chemo only arm, and patient who have responded in initial 6 months, they have done better, 70% compared to 39%, and even after discontinuation of therapy, response are maintained for more than or equal to 3 years, and it is a novel option with chemo-sparing. Next slide. So now I will discuss the 2-year update of this trial, which has shown very promising benefit, and it is now one of the standard of care. So in this phase 3 trial, patients were compared with Nivo-IP with 2 cycles of chemo compared to 4 cycles of chemo in first line setting. Next slide. So in this strategy, it is phase 3 trial. All patient without EGFR mutation were taken, and they were taken irrespective of PD-L1 status. So it is not done in other studies. So and they were stratified based on histology and PD-L1 status. So in this trial, compared to CheckMate 227 trial, in this trial, the nivolumab was given 3 weekly with 360 mg flat dose, and ipilimumab was low dose only 1 mg every 6 weekly, plus 2 cycles of chemo, and this was continued till progression and or toxicity, compared with 4 cycle of standard platinum doublet chemo. So primary endpoint of this study was overall survival, and this was regardless of PD-L1 expression. Patients with untreated brain mets were excluded, and autoimmune disease were excluded. And this is, we have follow-up of now around 30 months. Next slide. So in this study, we can see that based on almost all the factors were comparable. PD-L1 expression around more than 22% patients were PD-L1 level more than 50% compared to 29% in chemo arm. So all the variables were almost comparable. Next slide. So this in 2-year OS, this drug has shown around 15% benefit, 26 compared to 38% OS at 2 years. Next slide. So as this trial was irrespective of PD-L1 status, so even in patient with PD-L1 level less than 1%, it has 2-year OS is 37% compared to 22% in chemo only. Next slide. So PD-L1 efficacy even in PD-L1 status more than 1%. It was 2-year was 41% compared to PD-L1 more than 50%. It was 45%. So in both the groups, this drug along with chemo combination has benefited. Next slide. And in this plot, we can see that in across most of the group, Nivo EP with chemo combination has benefited. Only in patients who are elderly more than 75 years and second group who are never smoker, slightly chemo has shown some better. Next slide. Next slide, please. Next slide, please. He was mainly, as we have seen, that many patients get benefit with early chemo, and they hyperprogression is also prevented. Grade 3, grade 4 toxicity were 10% more in this immunotherapy arm, but serious adverse effect were also 10% more, but treatment related death were 2 in both the arms. So median and incidence of treatment related adverse effect were overall lower in Nivo EP plus chemo arm. Next slide. So similarly, like CheckMate 227 trial, it has shown that even after a patient whom we have due to adverse effect, this chemo or immuno was discontinued. They benefited from this study. Response were even in that 54% compared to 38% only in chemo only. Next slide. This you can see that skin, endocrine, and gastrointestinal were most common side effect, but in most of the cases, around 80 to 90% cases, all therapy, all side effects were manageable, and after discontinuation, like hypersensitivity reaction was managed in all patients. Skin toxicity were managed in around improved with supportive therapy in around 73%. And gastrointestinal toxicity improved in around 90%. Next slide. So skin, endocrine, and gastrointestinal toxicity were most common side effect with these drugs. Grade 3 were around 4.5% skin toxicity, and gastrointestinal 5.6% toxicity. Next slide. This typical chemo side effects were more in chemo arm, because they have received 4 cycles of doublet standard chemo. Next slide. So to summarize, at 2-year, OS was durable compared to chemo, around 12% benefit in Nivo EP plus 2 cycle chemo arm compared to chemo only arm. And good thing was that it was irrespective of PDL1 expression and histology. As we know that there is marked variability in PDL measuring PDL1 with inter-lab variation also. So that was also up. Then there was also no safe. It was safer drug, and discontinuation rate were relatively low. And even in patient whom we have whom this drug was discontinued, they benefited from therapy. Now this CheckMate 9LA has demonstrated this Nivo EP with chemo as standard first line patient, first line therapy for our mutation, EGFR mutation negative patient. Next slide. These were the 2 dosing strategies which were used in CheckMate 227 and CheckMate 9LA. CheckMate 227 was chemo free. CheckMate 9LA had 2 cycles of chemo. Ipilimumab was in both trial, it was 6 weekly till progression, and nivolumab was 3 mg per kg in CheckMate 227 compared to 360 mg flat dose in CheckMate 9LA, and it was completed till progression. Next slide. So for patient with CheckMate 227 has shown that with 4-year data that 29% compared to 18% versus chemo, and median duration of response was also long. And CheckMate 9LA, which was irrespective of PDL1 status, that has also shown 30%, 38% benefit compared to 26% in chemo only. Next slide. So, thank you.
Thank you, sir. Thank you for such a lucid talk. It was quite a big topic and it needed a good presentation, and thank you for doing that, sir. For our next session, which is sponsored by AstraZeneca, I would like to invite Dr. Amit Rothan. Sir is a senior consultant medical oncologist at Manipal Hospital, Bangalore, and he will moderate a case-based discussion on optimal management of first-line ES-SCLC. Over to you, sir.
Thank you, Nikhil. I thank you for having me here in this meeting. I also thank AstraZeneca for this opportunity. So let me just call on the panelists. We have Dr. Sushant.
Yes. Hi, good evening. I'm there.
Hi, good evening. Dr. Sumant. I don't think we have Dr. Sumant. Dr. Anita Ramesh. I don't think she's there. Okay. Dr. Basade.
Yes.
Yes. Yes. Okay. Dr. Ashish, I can see. Yes. And Dr. Srinivas, I saw. Okay. So great. Let's get started. Okay. So we'll go ahead with the case for first line small cell lung cancer extensive stage. So here's the patient, 62-year-old male, heavy smoker, presents with cough, breathlessness, weight loss, early satiety, found to have a massive liver enlargement. Scan shows a lung mass, mediastinal lymphadenopathy, hepatomegaly, and biopsy of the lung shows involvement by small cell lung cancer. It is IHC positive, and a brain MRI was also done, which shows no metastasis. So this is extensive stage lung cancer with liver metastasis. So let's start. Dr. Sushant, how are you thinking about in this group of patients? We finished the staging workup, we have a diagnosis, and what are your thoughts in this kind of a patient?
Sir, definitely this patient requires a EP protocol, etoposide platinum, and the choice of platinum would depend on his 2D echo status and creat clearance, and I suppose that is all right in this patient.
Okay, right. So you are happy with cisplatin, carboplatin both, right?
Yeah, I'm happy. I'm happy with both of them, and either of them would be fine with me.
Right. And how many cycles, and what are your views on other chemotherapy regimes?
I usually give 3 plus 3. After 3 cycles, I do a PET scan and then consolidate with 3 further cycles. And other chemotherapies such as irinotecan and all have not shown that great response compared to the old time-tested EP. So EP still remains the standard of choice for me. And 6 cycles is what I prefer in my clinical practice.
So absolutely what I think all of us follow: 3 cycles EP, do a scan, see response, and then 3 more cycles. So I think all of us go for 6 cycles. Irinotecan has a limited role, but I agree with you. All of us good. Platinum Eto is good for us. So now we come to the thought of the newer therapies. What now? Not new now. We have it for a few years, but I think all of us are slowly gaining experience. So let's get to the thought of the immunotherapy combination. So Dr. Basade, how are you thinking about for immunotherapy with now in extensive stage small cell cancers for first line setting?
Hi, good evening. Yeah, yes, in extensive stage, small cell lung cancer, immunotherapy has a role. now which is established. Both the drugs, durvalumab and atezolizumab, have shown good response. And the previously we have only anecdotal patients surviving beyond 1 year or 2 years, but now there are a lot of patients who are surviving even up to 3-year data is also there. So the first question, which platinum, I do agree that performance status, creatinine, 2D echo matters, but again, the presence of metastasis into the brain is also one we take into consideration, because what immuno I'm planning, because if there are brain mets, then atezolizumab, probably those patients were excluded in the beginning. So I would can use the cisplatin and etoposide and durvalumab, or carboplatin, etoposide, durvalumab, like that.
Right. So there was a difference, as Dr. Basade is telling us, in the trial designs of using brain metastasis patients. I think we will just show that slide again as we go further. So Dr. Ashish, is there any patient, so cost aside, I know cost is our limitation for all our patients, but if cost aside, is there any patient you would not offer immunotherapy, at least talk to your patients about immuno in the first line setting, or all patients in first line is where you think about in small cell?
I think we have enough data to say that a combination is superior. So unless until there is a contraindication of immunotherapy, I would go with the combination, and most of our patients, provided they are affordable.
Right. So I think now there's hardly anyone we can actually say no immuno, except if we rule out those immuno contraindications per se. That's the only thing. Otherwise, absolutely, in the present era, I think all of us, if our patients can afford it, we would want to offer it. So we have seen the clear improvement, though the issue used to be the survival benefit. The magnitude is to be, we used to look at the medians. We said in chemo era, we got 8 months, 9 months, and with addition of both the immunotherapies, we have approvals for durvalumab, atezolizumab. We saw the medians went up to about 12 to 13 months with a hazard of 0.75, 0.76. So there's always that talk, are you impressed with the medians, or are you not happy with that? Dr. Srinivas, what do you think? Are you okay with that median number? Do you think it's not a great benefit?
I think still we need to wait for more matured analysis, probably that would give the answer.
Okay. So you kind of think that 2 months is not good enough. What do you think, small cells?
I think because we are talking about a population which is a very extensive stage, small cell carcinoma, very aggressive disease. Whatever the benefit, it's a benefit.
Absolutely. I think in small cells, this is the way we will go forward. You will always get that small benefit, and then you'll probably keep adding on. But I think we should not look at medians, because once we see our survival curves, what we see clearly, I think I'll just get to those curves. Yes. What we are seeing here is we have the 3-year overall survival. And this is something that we have not seen till now in the small cell space. The immunotherapy data is at 3 years, showing 5.8% patients were surviving in the chemo arm. It's 17.6% in the Durva plus chemo arm. What we're seeing, tripling of the overall survival. And it's clearly significant. It's 12% more patients than what we see till now, what we have seen in small cells. As Dr. Basade mentioned earlier, we hardly had any patients. You can remember your patients who crossed 2 years. You'll have it in your fingertips, because there are so few of them. But now we are starting to see that number is getting slightly bigger. And this is the whole benefit of immunotherapy. You'll start seeing a little bit of the flattening of the curve, though it's not as great as what we see in non-small cells, but definitely it is benefiting, and the curves are clearly separating. So one thought is, any takers on why is it not showing that great response? We are saying these are all smoker populations. They are the ones which will have a lot of mutations. We kindly say all small cells do very well in terms of the ideal immunotherapy candidate. So any takers on why is it not showing that great response in terms, like in non-small cell, we see a huge number of patients doing better compared to this. Any thoughts on this?
I think it's because of the tumor heterogeneity. Lot of antigenic stimulations and lot of tumor heterogeneity is there in small cell. If we see neuroendocrine also, grade 3 also behaves like small cell. Small cell itself behaves like small cell. and we have so many combination of various genes which are acting and antigens. Probably that is the reason that we don't get that great benefit as we expect and as we expected.
Yeah. So what's been kind of explained is that even though you have a huge mutations, you clearly have that in small cells. They're all smokers, so you have a lot of mutations. But for various reasons, you have one of the most immunosuppressive environment in a small cell. And that is what is causing a problem. Though you have mutations, you have a very much immunosuppressive environment. So your T cells are not getting active enough to kind of get that sustained durable response which we are seeing in other malignancies where you have a high TMB. So that's the rationale they're giving as of now. But it's kind of very, very counterintuitive, and we keep thinking, these are the ones who should do really well. But again, we are slowly moving upwards, I would say that. So looking at the other issues, we're looking at the study designs, and so this is a question which gets tough in clinics these days. When you look at both the patients, durvalumab, atezo, both are approved. How do you choose between one of them, and what are your thoughts? Ashish, how do you think about in your patients?
I think both IOs has been shown, and there is no head-to-head comparison. But cross trial, we can say this is some patient profile, because both the patients having a little bit difference in the trial, because in atezolizumab only carboplatin is allowed, and in durvalumab cisplatin and carboplatin both are allowed. So it depends on the treating physician preference. I do consider cisplatin in a majority of patient, provided it is not contraindicated. So and that's score for the durvalumab. Otherwise, if I'm using carboplatin, I think both are the same as far as the efficacy is concerned. Some patient of the brain metastasis, I think durvalumab has the better data if the patient is, because in atezolizumab, they have included only patient who's treated for the brain metastasis. While in durvalumab, even the asymptomatic brain metastatic patient is also included.
Right. So this is what Ashish has already now mentioned to us clearly. So we had that brain metastasis untreated were not allowed in the atezo trial, and there were about 10% patients who had received. But in the Caspian, we had patients who were allowed both treated and asymptomatically untreated, and the cisplatin, carboplatin, and the other difference was 4 cycles versus 6 cycles. So in Durva, you see that you kind of got the ideal real world treatment which you get for most of your patients: 6 cycles, platinito and cisplatin carbo, or with radiation, without radiation. So all of that group of patients is there, and we have seen the clear benefit there. These are the cross trial curves. We don't usually just compare it and say that, but if you look at it, they're kind of very similar. And if you look at medians, again, they are very similar. It's kind of reiterating our fact that immunotherapy is giving benefit in the first line setting. It's helping us emphasize that this is the benefit we are getting, and we are hoping to get long-term data sets. And Caspian has 3 years data, IMpower still has 2 years data, but we are hoping that we'll probably get longer and longer data sets. So this patient gets on to Durva and gets a good response after 4 cycles, everything goes down, and then this patient is on durvalumab maintenance. And you do see such patients in clinic. We have some patients with long-term maintenance going on, though the numbers are few, but we do see that in practice. I had a question here. Now, Dr. Basade, what are your thoughts if this patient had liver mets, but had a little bit of altered liver functions? How do you think about immuno in this group of patients? Are you comfortable because of liver mets? Maybe the liver enzymes are 2 times normal, 3 times normal. Are you kind of worried of using immuno or no?
Yes, I mean, but in such cases, I would go ahead with the chemotherapy first in the first cycle. Once the liver enzyme settle down, then I will add the immunotherapy afterwards.
Right. I think that's probably the wisest thing to do in such situations. Just give your first cycle chemo, see the liver functions, whether they're settling down, and then probably add in. And I kind of think definitely a good idea. Dr. Sushant, if you had a little bit of a raised creatinine, are you hesitant of using immuno? Or so suppose you had a creatinine of 2, would you be hesitant of using immuno in this group of patients? What are your thoughts?
So I would definitely use carbo and not cisplatin first of all, and then if I think that is disease related, so I'll use first cycle without immunotherapy, and next cycle onwards, if the creat improves, then I'll add immunotherapy.
Right. So all of us do this in standard practice. We are very hesitant to add in the immuno if there are some dysfunctions. Though there's good data about at least liver, about kidney, there's really good data. If creatinine clearance is above 30, there's no contraindication per se for most of the immunotherapy drugs. It's said that you can use it safely. But for liver, we need to be a little careful. They have not been studied when liver enzymes are more than 3 times normal. So we need to be a little careful when we are using immuno with liver dysfunction. But I would say, in all practicality, we know most small cells will respond at least initially. So doing first cycle of chemo and then adding the immuno also makes clear sense. And that's what even I would kind of do in clinical practice. You gave your patient, you got a good response. Dr. Srinivas, now your patient is on maintenance with durvalumab and doing well. Would you consider PCI for this patient now in extensive stage?
No, sir. I don't do PCI unless the patient is symptomatic for brain mets.
Right. So you're following the Japanese data, which is no PCI. I kind of think it's kind of, we've gone through that whole loop. We talked about a lot of PCI earlier because of the European study. That was a long time back, but we used to give PCI to extensive stage to patients who responded. And then you had the Japanese study, which said that there's no benefit of doing PCI as long as you're doing good surveillance. Actually, the PCI patients did worse. So even we don't use PCI, except in very selected patients. Even we avoid PCI in patients who have responded well in extensive stage. So I think,
as you alluded in the prior trials, even those patients who are having the brain mets were allowed in one of the studies. IMP 133. Probably, I think immuno drug will take care of that, probably. And especially if the patient is on maintenance therapy, if the patient is stable and doing fine, I think.
Right. No, but we keep extrapolating our limited stage data, If our patients respond so well, PET becomes negative in 3 months, we get so excited in small cells, and then we think, oh, maybe let's do it. And I don't know, we don't have data about the immuno time. This is
my apologies, sir. You are left with 5 minutes to conclude your
sure.
discussion. Thank you.
Let's run through it. Right. So the other thought was radiation to chest. Ashish, do you radiate the chest after treatment if your response is good?
So I think even which you were talking the last slide, the brain metastasis, I think we have this data for only chemotherapy, because Japanese is negative and the ERTC data is positive. So we don't have a data for the immunotherapy patients. The patients is taking immunotherapy and doing good. I think there is no definite data to support that. But in our practice, if the patient is receiving chemotherapy, they have an extra thoracic disease are completely controlled and the residual lesion in the chest, I think I do give the consolidated radiation dose scenario, provided patient is not only taking chemotherapy.
Right. So I agree with that. Selected situations, all of us are doing radiation to the chest. Though selected patients, we have to choose our patients well, but there is some data that the benefit is there if the number of metastases was lesser, if the burden of disease was lesser, which is kind of common intuitive for us. If the burden is lesser, probably radiation as consolidation will help.
Dr. Amit, I just sorry to interrupt you.
Yes.
Do you believe that concept of making the tumor hot by giving radiation, and would it help?
That's a good question, because we keep thinking about what way could we get immune to respond, But I don't think in small cell we'll definitely be able to do it. We have been thinking about it in other tumors, but small cell is very different, I really don't think SBRT will include and increase our immune responses. There should be something else also there. That's the thought. But it's a good thought that maybe adding SBRT, and that's the reason why we keep adding it these days with immunotherapies. So we have clear-cut algorithms, and all of us kind of follow the same thing. I think brain mets was mentioned. Dr. Basade clearly said because of the data sets which we had, he would prefer durvalumab because durvalumab has more data in brain mets, and this is what we saw in the Caspian data, that patients with brain mets showed equally same benefit as the patients without brain mets. So lastly, a quick word. Dr. Sushant, do you do any biomarkers in small cell? Or are we reaching there?
No, sir. I don't do.
Nothing. Absolutely nothing. So TMV, we know, though we have high TMVs, we have very, very less sustained benefit. And we saw the trials looking at TMV, which are negative. And PD-L1 in extensive stage small cell is about only 5%. It's very low PD-L1 status, and it's really not helped. So no biomarkers. And last, maybe I think we were told time is up. So let's kind of how do you kind of look at managing poor performance station patients? Dr. Basade, your thoughts on that last question? Poor performance station patients with small cell.
So I will try to find out the poor performance status is because of what. It's because of the brain mets. Then we can treat and then treat the systemic disease. If the poor performance status is because of the large mass which is causing SVC obstruction or pericardial effusion, then you can do the pericardial tapping or pleural tapping and treat accordingly. So, you need to individualize the treatment. It's not that poor performance status patients will not do well at all. It's not. So you have to look into individual patient.
Right. I kind of agree with Dr. Basade's thoughts. And I think this is becoming very important nowadays because in many cancers, we are seeing responses can be got better. So it's not like the old algorithm where we said patients with poor performance, just leave them alone. There are ways by which you always say, if your poor performance is due to disease and if your disease can respond, your performance status will improve. So I kind of echo those thoughts what Dr. Basade has said. Always, if you treat the disease, if the disease patient gets better, their performance status is going to improve. So choose your patients very carefully. So I think with this, we will summarize. We have clearly seen first-line IO plus chemo in small cell lung cancer clearly has made its space. There's really no doubt about it, though the increment of benefit is smaller. But now you have 3 years data clearly showing a tripling of overall survival. And I think this is the most important factor, the durability of response. And these patients can be kept on maintenance. So a quick word on safety, it is very safe. And though we know we have to watch for IRAs, but we know, and all of us are getting experience in managing IRAs. So I think that's something we're all confident about. So with this, I thank all the panelists and I thank the organizers. I think I will stop now. Thank you very much.
Thank you.
Thank you, sir, for such a good moderation. It is always that in small cell, it is like it approaches so close, we get a good response, and then we know that we are going to fail. It's kind of place where you want to know where did we go wrong, kind of a scenario. Is it, what can we do to achieve a better survival? We end up knowing that they are not going to do well, but still we want to do something, which is kind of a tricky situation.
Absolutely, I agree with you. It's one of those situations where in your gut, long term may not be good, but you still get the euphoria when they respond. Yes. you in 3 months you're so happy to see that response, and you still know, yes, it will not last, but you always want that to last. But I think this kind of a data showing 3 years 15-16% is kind of very getting impressive. But I definitely think we need better things, and somehow if we could add on further responses, and there are a lot of things being looked at. They're looking at they're looking at why the tumor is so immunosuppressive. It could be the other molecules, and that's where it's looking at, can we add in other molecules to kind of reduce that immunosuppressive effect and try to see, can we do better? So I think we do have work to do in small cells.
Yes, sir. Thank you, sir. Thank you, sir. And I now call upon Dr. Mehboob Basade, sir. Sir is a senior consultant medical oncologist at Saifi Hospital, and sir will moderate a case-based discussion on is using the best drug first the ideal strategy in treatment of metastatic NSCLC. It is quite interesting talk, and I hope it is as enjoyable as the first one. Sir. Over to you, sir.
Thank you, Nikhil. Thank you for inviting all of us over here. And thank you, Astra, for giving me the opportunity to discuss the non-small cell lung cancer. Last time I discussed the small cell. Now this is the non-small cell. Okay, so let me invite my panelists, Dr. Kumar Prabhash. He was there just now. Dr. Rohit Pai, are you there?
No, sir, he is not there.
He's not there. Okay, so let me just put this off. Murtuza Bora.
Yes, sir.
Yeah, you are there. Satyam.
Satyam sir is not there.
Satyam is not there. Rohit Pai is not there. Shruti, I saw her giving a talk. Shruti, you are there. And Dr. Akash Tiwari. Yeah, Dr. Akash Tiwari. Akash. Akash, organizers say Akash is there or no? Okay. So are you able to hear me?
Yes, sir.
Yeah,
sir.
I thought suddenly everything, nobody is responding for Akash also. So I thought whether I'm not able. So I think Akash is not there probably. So let me start with the first, Kumar. So in the Tata Memorial Hospital, now what is the lung cancer panel? So, you are asking for all the patients. I know that, at the teaching institution or at the institution which is busy, so there might be some restrictions in asking. So what is your choice of the markers, what you ask for?
Sir, at this moment, we are doing EGFR, ALK, and ROS and PDL1 for almost all patients. Till some time back, we had a NGS which was available easily for us for an NC patient, which used to be around 2,000. So we are able to do for all. This time there have been cost revision and that has limited its use. But what I said earlier, that EGFR, ALK, ROS, and PDL1 we use for all patients. Sir.
So Shruti, you use these 4 or something else you add?
We do add once.
Yeah, Kumar, yeah.
And then I got it, sir. It was for Shruti. Shruti, please.
Okay, sir. Sir, so what we do in our hospital, Mehboob sir, actually we have created small panels for ourselves depending on the patient profile. So we have a restricted panel where we do EGFR, ALK, ROS, MET. That is the basic panel we do for everyone. We do not do BRAF, HER2 or PDL1 in those poor patients. And then we have a NGS panel which is costly for we do for well-off patients who are candidates for BRAF therapy or PDL1 based this thing, and which include HER2 also in that. So we have made small groups of panels for ourselves so that we don't say no to molecular testing for any patient.
Okay, so everybody is doing their own bit of things so that the patients ultimately get benefit. Murtuja, do you do liquid biopsy upfront for all the patients or selected patients? How do you do that?
Sir, not upfront. When on selected patient, like when the tissue is not sufficient and the repeat biopsy is not possible or very difficult. And sometimes patient preference also, they don't want to undergo repeat biopsy. Then we can think of the liquid biopsy. Otherwise, I generally prefer tissue block only.
Okay. Anybody else has different thought? Kumar?
Sir, I agree with the comment, except that in case if the resource is not a concern, then it is good to do both because you will add some in both ways if you do. But I do agree, by and large, there are very few patients when I explain them, they end up doing it. So usually if you have to choose, then tissue is the priority.
Okay. Shruti, as you might be doing PET scan for all. So when do you do MRI brain? For symptomatic patients or asymptomatic patients?
Sir, for symptomatic patients only, sir.
Only. Okay. Otherwise,
or non-metastatic. Yes, or non-metastatic. That's it.
No, and we are looking at metastatic disease only. Yeah. So for the patients, as they have undergone the EGFR and other targetable mutations, and the patient has found to be an EGFR mutation, and now we have various options either to give first, second, third generation TKI monotherapy alone, or EGFR TKI with angiogenic drugs, or EGFR TKI with chemotherapy in combination. And so these are the three basically an options. But the fourth option, Kumar, let me ask you, why EGFR TKI plus immunotherapy there are no phase 2, phase 3 trials?
Can you repeat, sir?
No, the fourth option, which is not here, but EGFR TKI plus immunotherapy.
Oh, EGFR plus immunotherapy. I agree with you, sir. I think so. That is something because they have not been able to show that. Looks like there is some additive action with them. There is an issue regarding complication. The additive action requires VEGF inhibitor, so that complicates the thing, sir. If one has to give it, till recently we thought looks like immunotherapy may not work with them. This TKI mutation when we give TKI and when we add chemotherapy, but there is some merit to it. But you have such good options otherwise. That's why at this moment, first line, that option is not there. In spite of two options being there, which one can consider, which is available at present. Yeah.
So in second line, because there
second
is
line, second line, yes, sir. Second line, yes, sir. I agree. ABCP is there, and now there is a validated data from Chinese trial. One can use it. I have used in some patient, but it's a bit complicated, sir. I always keep saying, I keep using this word. It is like treating like ALL patient.
Yeah.
For drug.
Conflicting data, yes. Osimertinib along with bevacizumab in second lines, it is positive. Some patients say that there is some people say that there is hyperprogression, so one should not be using it. So there are different. Murtuza, when you are starting treatment with the EGFR mutated patient, so what do you look for? Efficacy, safety, QOL, or all?
Sir, majorly efficacy and quality of life, because we know all drugs are more or less safe, but quality of life definitely matters, because I have seen that dacometinib having the worst side effect profile compared to the all TKI, EGFR TKI. Because I'm a PI of dacometinib trial, so I have seen majority of patient has skin toxicity and diarrhea, at least with the third generation TKI. That's why I will go with the see the quality of life as well as the efficacy.
Okay. So let me ask all three of you, what is your preference, starting with the Kumar first, whether you use second generation TKI, then move to the third generation, or first generation with anti-angiogenic drug and then third generation, and we know you are the champion of the TKI plus chemotherapy and then to third generation, or osimertinib upfront. So what's your choice, personal choice? You're mute.
If I have all the resources available, third generation TKI because of efficacy and the safety.
Yes.
But the real world is that only 5 to 7% of the patient they can take it. Now the issue remains, what is the choice? For those rest of the 95%, what we know that first and second generation TKI, excluding dacometinib, is inferior to other 4 choices. And out of other 4 choices, either you take dacometinib, or you take VEGF inhibitor combination, or chemotherapy combination. Chemotherapy plus TKI combination turns out to be the cheapest and most affording for the patient with a similar outcome. So that's a overall concept for me. But I won't debate with anyone if they chooses one way or other. But that's the concept I suggested.
So how do you take OS benefit of more than 50 months with chemo?
Yes, sir. You have more than 50 months. Okay. So that is a Japanese trial always with Jeftinib also. The Japanese trial, the median survival was 30 months. So our trial, the median survival was 20 months. And take Western world trial, median survival was around 20 months odd.
Yeah.
So they have always had those differences in the outcome, but the proportion difference has remained the same. And our overall survival data also suggested the same. We have just updated. We are putting in ASCO, and I won't say the number, but yes, it looks substantially improvement in survival proportion wise as compared to Jeftinib. So yes, it does improve survival. So now you have at least 3 options which improve survival, and that's one of them. That's a chemotherapy combination. That doesn't mean to say I'm saying that is the only choice. Sure, patients, when I discuss with my patient, majority, if they can afford, they want tablets, and especially the safer ones.
Okay, Shruti, what is your choice? 1,
Yes,
2,
sir.
3, 4.
Yes, sir. I totally agree with Sir Kumar, sir. First choice is number 4, third generation osimertinib upfront.
Okay.
Because I've seen many patients who want to take OSI and just die with brain metastasis even before the report of T790M comes. So I don't want such a situation for any patient ever. And so it is my duty to offer it to all my patients. Then in the other options, chemo plus TKI is I use it very, very frequently, and it is very well manageable with some dose reduction for pemetrexed. So DACO and afatinib even, the safety is an issue, and full dose tolerance is always a problem. So I also go in that sequence only, like Kumar sir mentioned, sir.
Okay, Murtuza, You were
Yes.
the PI, as you said that for the dacometinib. So dose reduction was not there in the trial.
So no, so dose reduction was there, but still after dose reduction, majority of patient has tolerate only 15 milligram. They're not able to tolerate 30 also. And all like skin reactions and diarrhea, these are the most frequent this side effect. And patient, none of my patient is on full dose. Like majority has on 15 and some is on 30. So just want to add one thing, as
Yes,
Dr. Subhash and Dr. Shruti has mentioned that if the patient is well affording, then we definitely go for osimertinib. But if the patient is non-affording and still having the brain mets and want the and PS is not very good, I will give the first or second generation TKI with angiogenic inhibitors. Because if you see the blood-brain permeability of bevacizumab is compared higher compared to the other chemotherapy. So is this combination also a viable option for brain mets patient, those who are not affording for osimertinib? So we can give, we generally use in our poor patients. Poor, that means those who can afford angiogenic inhibitor but not osimertinib.
So if they can afford bevacizumab,
can I put a number to it? Can I put a number to it? So
Yes,
you know, in principle, I agree with you.
Yeah.
But let's put some number to it. One is brain mets were included in that study, where chemotherapy TKI was given, and the proportion benefit doesn't change. It remains the same. The similar data for angiogenic agent is, we want to see that. Theoretically, it is good what you said. Second part of issue remains, if you're giving 15 milligram per kg body weight, and let's take 60 kg weight of the person, of that patient, then you are end up giving almost, it will end up around 50,000 rupees or 60,000 rupees per patient cost.
Yes.
Again, we have to find out, we have to bit concerned about how long the patient will be taking it. Then again, comparing those outcome with those ability to deliver comes in the question. That doesn't mean I'm saying that's not an option. Sure, that's also option.
Completely agree.
Yeah. So the last about these, the Kumar, the data of OC with bevacizumab didn't show much benefit. So theoretically, if it is better, then why not did it show benefit?
So I agree with you, sir. And one of those explanation was this question has been discussed by some other people. Looks like bevacizumab benefits when TKI doesn't work so well in brain. And here the problem is that osimertinib works very well in brain.
Yeah.
So that benefit, what we want to extract from bevacizumab in brain doesn't come here. But I do agree with you that this questions the I always say the concept. But I think so. Good thing is that that concept has been also answered in 3-4 trials now for bevacizumab and also for ramucirumab. So it looks like VEGF inhibitor does something. Maybe we can't overrule when we combine with first and second generation TKI. But yes, osimertinib data does put a dampener, and we need to be a bit careful. And that's why someone commented it will be important to see what happened when osimertinib is combined with chemotherapy.
Yeah.
Yes, because is it true that gefitinib it works, then we combine with osimertinib, it may not work. So
yeah. So if you look at the earlier trials of erlotinib and gefitinib, the exon 19 deletion 19 and the 21, the results, they were not different. But we know the difference is there with the afatinib and the other. So Shruti, what do you think? These drugs work much better in the exon 19 deletion, or what is happening?
Sir, I agree that there is a difference which is not seen with a third generation TKI. So I mean, it's hard.
There is a difference seen in 19 and 21 with third generation, but not with the first generation.
Not with first generation, but I don't see why it is. I mean, like with second generation also we see that difference. It is not there with the first generation. I think can't comment on how that is happening. Maybe at some pharmacokinetic level. I mean,
Kumar, any thoughts on that?
Sir, I think so. With the previous generation TKI, what we have seen that proportion of benefit is similar.
Yes.
Prognosis is different. So exon 21, the prognosis is poorer than exon 19. But for example, I just giving a analogy that if the PFS was 5 months with chemotherapy, the improvement is 20% and 6 months with chemotherapy for exon 19 and 5 months with exon 21. The proportion difference is similar. The absolute number changes, so prognosis is, becomes different. Yes, what you are raising a question, sir, that if we take dacometinib and we take ramucirumab, I'm just naming it to make it explicit. Is there a question regarding that exon 21 and 19, the benefit, that part changes, and then it starts overcoming that prognosis what we have? So I always say that's not a clear-cut answer to it. But when you have a 5 option, we all start choosing, and I do believe in that you have a 5 option. Choose 5 option where you want to use. Otherwise, those modalities goes out of window completely. And I always give example of high-dose interleukin. We didn't use it. It was there in Indian market. Now it is not there. So I say yes. That makes a bucket out of it. For this bucket, we can use these kind of drugs. But we are creating the bucket rather than it's being. It's been proven to be there.
So theoretically, people are saying
with
that
some merit. Yes.
Yeah. So there are co-mutations.
So brain mets is there. 21 is there not.
So theoretically, there are co-mutations associated more with the exon 21 as compared to 19, and that's why survival of 21 is lower compared to 19. Sorry, sir, we missed you. Can you hear me now? I will put my video off.
Yes.
So,
no, sir. Go ahead. Sir.
Yeah. Now, I mean, the mutations associated with exon 21, the co-mutations are probably higher in number as compared to 19. And that's where the survival of 21 is supposed to be a little lower compared to 19. 19 do better. And that's the drugs like osimertinib, etc. They have a better coverage for all these mutations. So they are doing better. That's what the theoretically possible. So yes, we know, yes, yeah, we know in Flora there is a very important, we already discussed about the sequencing. Everybody wants to go ahead and give the osimertinib first, the 3rd generation, because Shruti said that many patients may not be able to go to the further treatment ritual because of the brain mets and other things. So we would like to go ahead and continue the treatment with the other things. So what happens if somebody progresses on the osimertinib? Let me ask Murtuza. So what's your choice of treatment when somebody progresses on osimertinib?
So generally, I give the conventional chemotherapy like pembrolizumab based or cisplatin based dual chemotherapy if patient's PS is good.
Okay. Okay. You don't use immunotherapy or something like that? Single agent?
So as Dr. Kumar Baba has already mentioned, that some previous data is not very supporting or encouraging to use immunotherapy in especially any biomarker positive patients. But if we don't have other options like PS is not very supporting the use of chemotherapy or engineering inhibitor, then I will use with proper explanation to the patient the immunotherapy.
Okay, Shruti, what's your choice after osimertinib?
Yes, sir. Post osimertinib, I have used immunotherapy nivolumab for a patient, and he subsequently received many more lines of therapy and ultimately died of COVID. But yes, you have to be careful of using immunotherapy after you have used a TKI therapy. There is a class effect, and you have to be careful of the immune related side effects at that point when you are switching from immunotherapy from TKI to immunotherapy. That you have to have a gap. I guess as far as the literature is concerned, immunotherapy or a second line chemotherapy is the only option that is there. And recently post amivantamab for a 20 insertion patient, I have started the AB PA regime, and I'm yet to see how this patient does. So I guess chemo plus immuno or maybe immuno alone is the option.
Kumar?
First and second generation TKI, it is easy one. Do a repeat and hope for that you have T790M and try to get the tablets somehow.
Yes.
But if you can't, then I agree. Chemotherapy plus immunotherapy plus bevacizumab. And osimertinib, that's a problem. And theoretically, you have multiple options. You hope that MET amplification will be there, MET mutation will be there. You have 797.
Request, sir, you to conclude the panel discussion
Yes,
as 5
that's-
minutes are left for you.
Yeah. No, we'll finish before that.
HER2 will be there, RET will be there. But in practice, hardly I find. So, I end up most of the time giving chemotherapy and sometimes giving immunotherapy plus bevacizumab. So
Can I say
osimertinib, excellent drug, but subsequent therapy, we are learning. I think so with time. Sorry, I interjected. Go ahead.
No, sir, I interjected actually. Sir, I wanted to ask, my observation is that post progression on osimertinib, we don't see that many MET mutations, which we see after first and second, first generation. I don't have experience of seeing MET after second generation, but many patients after first generation I've seen a coexisting MET mutation as well as amplification that I don't see that frequently for osimertinib. Maybe the number is also lower in the other group, but what is your personal experience in that regard, sir?
I agree with you. Post osimertinib, what we see data in the book is not what we have seen in the clinic. And we keep talking about it. Let's see. Once we have, what you said is important. Once we have those, 70 or 100 number, we can say about those number rightly. But yes, a bit uncomfortable after osimertinib. We want some better therapy to be available. Osimertinib per se, excellent treatment, but post osimertinib, by and large, chemotherapy.
So what we do is we try to get the NGS done again, liquid biopsy. And if it is only limited MET, then local radiation can also be a choice of treatment, and continue osimertinib or systemic therapy in the form of chemotherapy plus minus immunotherapy plus minus bevacizumab. Can the triplet come in, addition of cetuximab to the combination, doublets? Kumar, any thoughts?
Sir, one should consider, sir, response is good, side effect is a problem. I'll say response is fair, I won't say good, but it is fair. But side effect is a problem. Almost everyone develops that bad rash and the diarrhea. But one should try modifying doses. I have tried in few patients, but tough to deliver. But
Yes.
It's a fair option, sir.
So
So can I just interject one? Have we tried osimertinib 160 mg type? Since we are talking about increasing the dose. Changes.
So 160 in CNS mets, I've tried both ways upfront, and when the CNS mets has happened or leptomeningeal disease is there, then increasing the dose. Upfront looks good, but upfront 80 also may be good. When there is a progressive disease, then doubling the dose, not so great. Not so great. Some people become better. Like there are people who said, I don't want injectable at all. Then I'm safe. Otherwise, initially I used to be bullish about it. Nowadays, not so bullish.
Okay, so the last slide from our side, then we conclude the panel discussion that osimertinib is the one of the best therapy to be given first because of its good response rates, good OS, good PFS, good quality of life, in fact, better than the first, second generation, and it will be safe. And so that every patient of ours who has the EGFR mutation should go ahead with the osimertinib. That should be the first line for the majority of the patients. So anybody wants to add last comment, and then we will hand over to the Nikhil.
No, sir. Thank you. And nice to see Dr. Shruti and Dr. Nikhil.
So Nikhil, over to you.
Thank you, sir.
Sir, thank you.
Thank you.
Thank you.
Thank you, sir, and thank you to everyone for joining in. It somehow felt like it should never end, but unfortunately, it has to. I now call upon Dr. Tejinder Singh, sir. Sir is a senior consultant medical oncologist at Apollo Hospital in Mumbai, and sir will moderate a session sponsored by Roche on optimal sequencing of ALK-positive TKIs and ALK-positive NSCLC. Over to you, sir.
Thank you, Nikhil. And a virtual activities. I think everyone is hungry at this time. So I'll invite my panelists, Dr. Jayant, Dr. Ashwin. I can see both of them, Dr. Samir, Dr. Murtaza, and Dr. Tushar. Tushar, I'm not able to see. Tushar is there? Oh, sorry, it's not.
Okay, fine. So I think Jayant is there, Ashwin is there, Samir and Murtaza is there. So this is a case-based scenario, decision-making things. This is a not like my patient. This is a theoretical case of a 50-year-old Indian woman, no history of smoking, severe left back pain, breathlessness and cough for last 3 months. And the CT scan shows a solitary tumor in the left lower lobe with moderate ipsilateral pluripotent. Turned out to be adenocarcinoma, moderately differentiated, EGFR wild, ALK positive by ISC, and PET scan was done, which showed lung carcinoma with pluripotent. In the PET only, there was a CNS disease which was seen apart from the spinal mets. So this is a case of lung cancer, stage 4, ALK rearranged. So my question to Dr. Ashwin is there regarding the CNS, talking about the brain MRI. Do you do the brain MRI before starting ALK therapy or not?
Sir, am I audible?
Yeah.
So routinely I don't do it. Only if patient is symptomatic or if I get any evidence on PET CT, then only I advise, or else no.
So your question is basically no, right? Dr. Murtaza, you are doing for every patient or only symptomatic patients?
No, sir. I routinely advise MRI brain to all my stage 4 or advanced patient, because sometimes we know sometimes some asymptomatic brain mets are also there. Then we have to choose before choosing our ALK inhibitor or EGFR TKI. We have to know about the brain status. So I routinely advise. Sometimes because of financial situation don't do MRI, but I advise and I want preferably patient undergo MRI brain.
Yeah, because if you see the first line drugs which have got approved or preferred, basically even though they have CNS penetration, that most of them they don't require an MRI over there. Anyway, it's a very good thing you said. Dr. Jayant, do you do the MRI or no?
Yeah. So what we do at our setting is we do a dedicated brain imaging when we do the PET CT scan. And what we have found that we most of the times pick up asymptomatic mets in the PET scan itself. So we are not doing brain MRI as a separate thing for CA lung patients.
Okay, fine. Samir, what is, you do the same thing or you go ahead with MRI or no?
Yes, sir. I also prefer MRI doing routinely if patient is affording.
Okay, so you put the affordability over there. Otherwise, naturally, everything becomes a different story.
Right.
If the affordability is not there, then you have only one drug which you can think about giving.
Yes, that then doesn't make any difference in my treatment.
Right. I think it's very important thing to understand that, so one way or the other, I think most of us do think the presence of CNS metastasis, it impacts the decision in our cases or not. Samir? If the CNS mets is there, your thinking changes or you go with the same goal?
Basically, sir,
doing the MRI. Since you're doing MRI, naturally, it will change, right?
Yeah. So basically, sir, for me now the crizotinib is now out first line. So for me, it's always second generation versus lorlatinib. So I think means even if the brain mets is present, so alectinib is also a fair choice. Okay, but maybe we have to think and give the option of lorlatinib also. But otherwise, if the CNS mets is not there, definitely the first choice is alectinib for me. So I think it helps in making decisions slightly and counseling also.
So if you are looking at the cheapest option, which one you will go?
Cheapest, then ceritinib.
Fine. I think very practical thing what you are talking about. That's Jayant, any different thoughts or the same thing? Dr. Jayant, same thing.
Yeah, same thing, sir. If there are CNS mets, then second or the third generation would avoid the first.
So how much percentage you tend to see asymptomatic mets in your ALK positive patients in your practice?
Maybe around 30%.
Right. I think it's quite good. Samir, same thing or you feel it's more?
What's up?
The CNS asymptomatic metastasis, ALK positive patients.
Yes, around same 30% around.
Yeah. I think we are seeing in the same tune of around 30%, but most of the brain mets are asymptomatic. They don't get picked up even with the PET scan. This patient had a scan based on the PET scan, the lesions got picked up. But tendency to have a asymptomatic is very high with ALK, similar like EGFR. But the trend is changing now. Everyone is doing the MRI. That should become a part and parcel of most of the things, because we are deciding the therapy based on that, the CNS metastasis also. So it does impact our treatment decision. Small point to view and answer about the baseline, the importance of baseline brain scan. You can see the ALEX, ALTA, and CROWN study, and where the PFS also basically in those patients where there was no brain mets, and those patients who had brain mets, there was a difference in the PFS. And so if you see all this trial from the alectinib to briga to lorlatinib, patients who had brain metastasis, they have underperformed in many trials. Any comments on it, Ashwin?
Yes, sir. As compared to crizotinib, I think second generation and third generation.
Basically, now crizotinib is becoming like a poor arm for everyone.
Yes,
Everyone has done a trial comparing with crizotinib. So, and somewhere a reason could be the penetrance of the brain mets is not there in crizotinib. So the important thing is when we talk about the CNS as a site of metastasis, it's a most common site of progression when you are talking about patients treated with the crizotinib and ceritinib. The first site of progression on a crizotinib, the percentage is nearly 50% of negative cases. Similar with ceritinib also, it's in the tune of around 40 to 45%. And we know the reason why it occurs and the mechanism of resistance. Alternatively, this CNS progression may be due to insufficient penetration of this ALK inhibitors into the CNS, which enables the CNS as a century site. So, Dr. Samir, at the time of progression, you are doing again a molecular analysis or no? Looking for the resistant mechanism?
Yes, sir. We should do it.
Okay. You do routinely or no?
NGS. Routinely, if patient is affording again.
Yeah, I think we are here only for looking at the affording patient, because we know from the first line, from what to do. Then now the whole things have changed.
Right, so we should do it.
So, So, Dr. Jayant, I think, can you elaborate the key factors when you are deciding on selecting the first line treatment? Looking at it now, you have so many options. We are now in the same way like EGFR, like the previous talk of Dr. Kumar. So Dr. Mehboob Basade and Dr. Kumar was telling. So we have so much of choices now. So how do you decide in your practice?
So basically, it is for us, it is second versus third generation.
Right.
There is no data head-to-head between them. So we have to fall back on cross-trial comparisons for the two. Now, when you look at a cross-trial comparison, again, if there was an overall survival data for the two, that would be the best thing to compare. You don't have an overall survival comparison even in the cross-trial setting. Then we come to the response rates, overall response rates, the CNS response rates, the rates of CRs, and then the toxicity. These are the factors which help us to decide which drug you're going to choose. I think looking at the cross-trial comparison, lorlatinib seems to be better than alectinib as far as the cross-trial is concerned. Even if you look at the toxicity profile, you look at the discontinuation rate, they are almost numerically, they are almost the same, but numerically alectinib had a higher discontinuation rate as compared to lorlatinib, even though lorlatinib has more grade 3-4 adverse events as compared to alectinib. Then the next thing would be, how are you going to sequence your treatment after second and third generation? That would be again a factor while you decide what treatment you're going to choose first line. And finally,
I think the whole thing basically is going the same way like the EGFR, where there's a lot of talk about the sequencing and the best drug to use it in the first line. So Dr. Murtaza, anything you feel is different? CNS is a criteria now. CNS has become a very important criteria. Even in the EGFR, but in the ALK also the CNS has become a criteria. Anything else you feel is a criteria when you talk about looking at the consideration for the first line? Leave the cost factor.
Okay. No, sir. I basically see for the like brain disease as well as the sequencing patterns. So I'm totally agree with Dr. Jayant. If we want to sequence, then we should like think alectinib followed by lorlatinib or lorlatinib followed by what mutations we got in NGS. So if we have some other options for uncommon mutations, then these are sequencing and brain mets will be my key factor for deciding upfront therapy.
Yeah, I think the only thing which is going to give us a good answer about is, apart from the looking at the clinical evidence, you will never get a trial to directly do a head-to-head comparison. This will never happen. The efficacy in the first line and is going to be a big factor. CNS, luckily, we know that the first line, the good second generation, and Lorna has got a very good CNS penetrance. I think this is something we know. And long-term safety, resistant pattern, we have been struggling with drugs like, the crizotinib and alectinib. Our basically experience is not so great right now with the lorlatinib because it has just come in the picture. I think second thing is that alectinib, all of us have used it for a good amount of time. And a resistant pattern, we do talk, but the previous discussion which was going on was which is the best drug to use at the first time. You cannot keep it for the second time because the survival happens based on that. Yes, this talk about sequencing and using in the first line will always be there. But yes, I think the problem which happens is a progression. When it progresses, the resistant pattern makes you go back to only one thing, that is immunotherapy or chemotherapy. Most of the, if you see the lorlatinib and other things, the problem with the lorlatinib is only that when they do have a resistance, most of this resistant mutation, they do not respond to any ALK inhibitor. So you have to go back to the chemotherapy. So
Sir,
this sequencing,
regarding toxicity, definitely lorlatinib is much more toxic than alectinib. So I don't know much.
It's not so easy drug. The hypercholesteremia, I had two patients of mine, both I had to stop it only because of many reasons related to the lipid profile issues. Nothing.
Even CNS toxicities are seen with lorlatinib. Even peripheral neuropathy is quite common. Edema is quite common. So as such, lorlatinib is definitely looks toxic, more toxic than alectinib. Alectinib is much easier to give.
Yeah. So alectinib, I think one more thing is, Samir, maybe I think we are more happy with alectinib because all of us have done it. We have a good experience about using alectinib. So we have been using alectinib and the side effect profile is almost similar like Crizo only, except for the, all this pedal edema and other things is the only toxicity. And ALK, you remember, they are much better than the EGFR. The life survival is much better with the ALK patient as compared to.
Actually, sir,
Samir is a co-PI of lorlatinib trial. So he has a more, I think, more experience with the lorlatinib toxicity and the management. So he can guide us better about how he managed in all his trial patient.
I've seen almost all the patient had some toxicity. Almost hypertriglyceridemia, hypercholesteremia, almost seen in all patients. Neuropathy in almost more than 50% of the patient. CNS toxicity was seen in one patient. And peripheral edema almost more than 50% of the patients. So I've seen significant toxicities for lorlatinib.
So this hypercholesteremia occurred very early or a little bit late?
Immediately, sir. After 2-3 months, it start developing.
That's I think the first 3
almost all patients required atorvastatin, statins. Almost all patients. Even triglyceride significantly increases. So
I feel that Lorla is a very different. It's not so easy drug to use it. Right. I had 2 patients experience. But both these patients, basically, I had used it after the alectinib failure, to be very honest. I had now used it in the first line. And both these patients had a lot of issues, especially in the first 3-4 months, with the managing the lipid profile. So Dr. Jain, somewhere I feel Lorna is more difficult with whatever experience I have. Just like that.
Sure, sir. I have no experience. But on paper, yes, it looks more toxic.
Ashwin, you had any experience with lorlatinib? Most of us, except if you have been in a trial, then only like Samir, you must have seen in the first line, but most of us have used it in the second line only.
Yes. Sir, but looking at the side effect profile means for a non-metastatic non-metastatic setting, I think better would be to go ahead with sequencing of alectinib followed by lorlatinib.
So that is why, this discussion about this discussion about sequencing and all those things will be there continuing for the next 2-3 years. Don't worry about it. So I think, Samir, what is your first choice? You are more preferring the sequence or first line the best? Lola, the data is coming very strong. Huh?
Yeah, right, sir. So for me, right now, if the brain metastasis is present, the option of lorlatinib may be discussed and explained about that, everything about toxicity and everything. And again, after lorlatinib, we don't have any data other than chemotherapy, what can be given. Alectinib, definitely the brain mets are not there. I will prefer alectinib followed by lorlatinib here.
So you prefer in sequencing?
Sequencing in brain mets also. See, alectinib also is good for CNS.
No, you have to go with one choice. Yeah, there is something
sequencing.
Sequencing. The same thing you can't discuss. Dr. Jayant, what will be your thing? Sequencing, or you will go with the first drug?
I would go with the third line, third generation. First.
Third generation. Good. Ashwin?
Sir, sequencing. Alectinib followed by lorlatinib. Yes.
So I think Murtaza will follow Samir.
Once we are failed with alectinib, I think Roche does provide NGS support also. So I would go with sequencing.
So anyway, Murtaza, what will be you will prefer the best drug in the first, or you will go for the sequencing?
No, sir, I will definitely go with the sequencing, as I have seen some toxicity with lorlatinib also with some Samir's patients. So I will prefer to go with the easy drug first. Then we will see in subsequent setting lorlatinib.
Yeah, basically,
till date now it might be changed. The practice might be changed in the subsequent years, but till now I will prefer alectinib followed by lorlatinib.
So basically, what I had been doing the last 6 to 8 months is the same thing. I had been giving an option, but I give the personal choice to them to go ahead with the alectinib first and then go ahead with the lorlatinib later on as a sequencing. But like what Murtaza said is very right. Our perception might change in the next few years. When you talk about osimertinib and the afatinib, there the osimertinib is very less toxic. You see the toxicity profile of osimertinib is much less as compared to afatinib. Here the only problem which is going to be a thing is a cost, and second thing is the toxicity, which might make us think about something else. So these are the currently first line approved. We all know crizotinib is also part of the line. Ceritinib is the poor man's drug, still I say, because this is much cheaper among all, because the generic version is available. Alectinib is a drug which most of us have started using the first line in affording the population. Because the availability is issue, and Lorla has come up in a big way now. It has got a first line approval in March 2021, and the EMA approval is still not part of the thing. Alectinib came around 5 years back, and like I said, our experience with alectinib has been quite good. Remember one thing: when you see there's no cross trial comparison. You try to go ahead with the cross trial comparison and give an answer, but you will never get a cross trial comparison. Everything will be against as a crizotinib. Most of the thing ultimately will have to decide based on the either a new trial which looks at the sequencing, or based on the experience, or based on the side effect. So the median PFS you can see is approximately 3 years with the alectinib. Here, it's showing a good, we have to just wait. The data, I think, right now the data is looking very promising, but the whole battle in the next few years will be whether you prefer the sequencing or whether you go ahead with the best drug in the first line. So these are the way we look at it. Just now we discussed, when you talk about there are trials where post alectinib, like Ashwin said, Lorla has come up in the second line based on the NGS we do it. You can see the way the median PFS moves from 34 to extra 5.5 months approximately, going towards the 4 years. So brigatinib also is a good drug, but as compared to alectinib, slightly inferior, and its availability is an issue. So normally when you talk about the first line, the second line chances basically with the lorlatinib is little bit on the better side, because we know the resistant pattern, but the whole game line is changing. Talking about the Alex trial, PFS by baseline CNS metastasis status, you can see the difference. Patients with or without CNS metastasis, the PFS was much better in the patients who do not had CNS metastasis as compared to crizotinib. And even patient with CNS metastasis, the PFS was, approximately 2 years. So it provides benefit, PFS benefit, irrespective of CNS metastasis at baseline. So that's a real question comes in that asymptomatic metastasis patient, whether really we need to do MRI, but most of us have started doing it as one of the part of the criteria over there. So CNS progression in patients with or without metastasis, alectinib, it protects against and treats the CNS metastasis, and it's significantly delayed the time of development of new CNS metastasis and the progression of existing CNS metastasis. So you can see a difference where the CNS progression gets delayed in those patients who do not have CNS metastasis at baseline. So this is a 5-year OS data after a duration of nearly 48 months for alectinib. The OS data remains immature. 37% of the events were recorded. You can see the difference also as our ratio of 0.67. And these are the 5-year survival rate when you talk about alectinib versus crizotinib. You can see even for crizotinib, the 5-year survival rate was quite good, 45.5. And for alectinib, it was nearly 62.5. Like I always said, ALK disease, I feel always they do well better than the EGFR patients. So when you talk about alectinib, it shows a clinically meaningful improvement, 62 versus 45.5% with the crizotinib. So this is the safety, looking at the safety profile. I think the important thing to remember is alectinib is, all of us have gone through it. The serious adverse events were seen in some percent of patients, but the fatal adverse events were very less. The AIs leading to treatment discontinuation was around in the tune of around 14.5%. So, but with a 3 times longer treatment duration for alectinib, the rates of reduction, interruption, discontinuation were similar with alectinib and crizotinib. So it's a quite well-tolerated drug over a long-term use. So, Samir, what has been your experience with alectinib?
Sir, I've used in 2 patients, and I think both of them tolerated well. There were no toxicities, significant toxicities.
Okay, so main toxicity which you found was more related with the edema or something else?
Actually, sir, both of the patients had no toxicities. They have tolerated extremely well. There were no issues.
Okay, Dr. Jayant, what has been your experience?
So I have one patient with alectinib. He had presented with CNS metastasis. So he received radiation and then he's on alectinib since last 3 years and absolutely no toxicity.
Yeah. Ashwin?
So 2 patients I had seen. One patient is in CR, 3 years with no toxicities. Another patient was there a bit of, apart from anemia, but it is no manageable toxicities, no serious toxicities.
Right. So, Dr. Murtaza, anything looking at the safety, tolerability, I think you feel it is much safer and easy drug to handle?
Yes, sir, definitely. If we compare all other third generation like lorlatinib, and if we compare alectinib, much more safer compared to lorlatinib. Only some in one patient in my residency days, I have seen the LFT derangement. I have seen. Otherwise, in my practice, 2 patients I use in 2 patients. Both are doing well. No any this LFT toxicity or other toxicity mentioned in the literature. So they are tolerating well.
So I think it's basically our experience which will help us going ahead with the alectinib. That's one of the reasons why we are more comfortable.
Sir, basically means, as you said, like EGFR, here the story is same. But if you see comparison to EGFR TKI, here the difference is that here second generation ALK inhibitor are much more better.
Yeah.
In terms of efficacy, they are better. Toxicity, they are better. In EGFR, what is happening? The efficacy is much less and toxicity is much higher. So that's why here the picture is slightly different. Here it may be difficult for third generation to come in first line, maybe. But we never know. We have to wait for 2-3 years, and then we have a PFS and OS mature data. Then we'll have a better answer. But right now, I think second generation, they are definitely much more efficacious and much less toxic.
So I think the whole story will look into the toxicity and the thing, nothing else, you know.
Right.
You have any vision issues with the crizotinib? You have seen any vision issues?
Sir, one patient in TMH, sir, he had one issue. I remember it was 4 or 5 years back. Otherwise, not significantly, means I'm not seen much.
Yeah, Dr. Ticharenja sir, to conclude the panel discussion, as 5 minutes are left, sir. Thank you.
Yeah. So I think this is looking at the toxicity of crizotinib, you know, the safety data, and the ceritinib. When you talk about the ceritinib, the main issues which I had seen is the GI adverse events as compared to anything. Ceritinib is not so easy drug, but GI disturbance are very big problem. And this is a trial, I think someone had presented it also, the CROWN study, phase 3 CROWN study. And you talk about the grade 3, grade 4 adverse events quite high, adverse event leading to permanent discontinuation, even though here it looks 7, but the grade 3, grade 4 side effects were more around 72%. And this is what I think Samir had been going on telling about the first two, hypercholesteremia, hypertriglyceridemia. Initial days, it becomes like a big issue. You know, they come with peripheral neuropathy. They have this increased triglyceride, hypercholesteremia, and cognitive effects. Cognitive effects are quite prominent, which I had seen in my practice as peripheral neuropathy. So this is basically, like I said, cross trial comparison, looking at the overall response rate. The lorlatinib, it was around 58% as compared to 75% with the crizotinib. CNS also both did very well, and the main thing which is going to be the thing is the toxicity, the grade 3 side effects leading on to discontinuation. The discontinuation adverse event dose interruption was in the tune of 47%. And even though here it talks about discontinuation basically around 15% as compared to 9%, but the dose interruption which we commonly see with lorlatinib is very common. So I think this is a question which I asked. Most of us are looking at sequencing. We might go ahead with the other way out, but right now our preference is more into sequencing, because it's a drug where we talk about the preventive approach. We have one more second line drug which is available, and it will help us in countering that thing also. So I think I'll just summarize. These are the guidelines from the NCCN for the second line. Lorla is always there. So this is what I was telling about the treatment sequencing. I think it's something which is, we are going to look at this 40.3 months. These drugs, they progress basically. I think the only option is going ahead with the atezolizumab, bevacizumab combination, or going ahead with only chemotherapy. This, I think the IM Power 150 was the only trial which had looked into that particular group of patients. So of the 5 approved first line treatment option, alectinib is still the preferred first line and standard of care, because it has demonstrated the longest PFS. It effectively protects against and treats the CNS metastasis. It's the only ALK TKI to have demonstrated a clinical meaningful benefit in OS versus crizotinib, and it's a well tolerated. We know about it, its safety profile when we are giving it for a long term. We have patients who have been taking it for the last 3 to 4 years also. So a wealth of evidence for alectinib in the first line for the support is used in the with the consistent results in the 3 phase 3 trials also. So upon disease progression, we have second line drug also. Thank you everyone for a very nice discussion.
Thank you, sir.
Oh,
I think Nikhil Kumar sir is there. We can ask this question to him. What is his preference right now?
So I think sir must have been answering these questions, like, after the Lorla has come over there. Sir has got a very rich experience in the first line because of the trial things also.
I also think it also depends on which side are we speaking on. Is it a Roche sponsored session or is it?
Yeah, I think that, but somewhere down the line, the only thing which is going to make us decide is the toxicity. OC somewhere came in the first line because of his, hardly any toxicities.
Yes, sir.
But still, the time will tell us much more. Once our experience becomes better, I think we'll be able to answer it.
Sir, I agree with you. And I think Norla at 100 mg is quite toxic. And I agree to that. Probably it will go somewhere down the line, Dacomethrin kind of picture when, we step down one dose and...
Yes, and try to get the same result. Right?
Yes, yes, sir.
So Lola, the main issue is that the dose, I think once they bring it down, I think we might see, but it has to work in the same efficacy way also.
Thank you, sir.
Yeah.
Thank you, everyone. And thank you, everyone, for joining. And it's a Sunday evening. I just can imagine where everyone is doing it with so much enthusiasm. And at the end of the session, I would like to thank everyone who has participated with such enthusiasm, with such vigor. And we had brilliant discussions on both days. We had good talks. It is to the say, this is the entire credit also goes to Dr. Amol Dongre sir, who has been behind planning this session and making it sure that everything works out. Sir has been relentlessly working on it for the past, I think, 6 months. And to Tarun sir, Tarun, you have organized it brilliantly, and hats off to you. I thank all the participants, all the organizers, and all the attendees for making this conference a success. Thank you.
Thank you, everyone. Thank you, everyone, for joining. And thank you for the excellent discussion and presentation. And I would like to thank my organizing team, especially Garima and Aram, who has put a lot of efforts. And thanks a lot to you. Good night. Stay safe.